Your learning objectives for mastering the general survey are to assess and describe the patient's general appearance, including level of consciousness, signs of distress, apparent state of health, and facial expression, to assess the height, weight, and build of the patient, and to measure the vital signs, including the blood pressure, heart rate, both radial and apical, respiratory rate, and temperature. The general survey of the patient's appearance, height, and weight begins with the opening moments of the patient encounter. Does the patient hear you when greeted? Rise with ease? Walk easily or stiffly? Each observation should raise questions or hypotheses for you to consider as your assessment unfolds. The best clinicians continually sharpen their powers of observation and description throughout the patient visit. Before beginning any physical examination, elicit a careful history to clarify the patient's concerns. Common or concerning symptoms relating to the general survey and vital signs include pain, fatigue and weakness, fever, chills and night sweats, and changes in weight. Pain is one of the most common presenting symptoms in office practice. An estimated 76 million Americans report intermittent or persistent pain each year. The 7 features of pain, especially severity on a scale of 1 to 10, localizing symptoms, and the psychosocial history are essential to your physical examination, assessment, and a comprehensive management plan. Fatigue is a relatively nonspecific symptom with many causes. Because fatigue is a normal response to hard work, sustained stress, or grief, try to elicit its associated life circumstances. Fatigue unrelated to such situations requires further investigation into causes such as anemia, thyroid disorder, depression, cardiac ischemia, and several others. Weakness is different from fatigue. Weakness denotes a demonstrable loss of muscle power and bears careful investigation. Question the patient as to what areas of the body are involved and any associated sensory loss or other neurologic symptoms. Fever refers to an abnormal elevation in body temperature. Ask about fever if patients have an acute or chronic illness or especially infection. Recall the 7 important attributes of every symptom. These include location, that is, where is it and whether it radiates. Quality, can the patient describe what it is like? Quantity or severity, if there is pain, can the patient rate it on a scale of 1 to 10? Timing, when does it start, how long does it last, and how often does it occur? The setting in which the symptom occurs, that is, environmental factors, personal activities, emotional reactions, or other circumstances that contribute to the pain. Remitting or exacerbating factors. Is there anything that makes it better or worse? And associated manifestations. Has the patient noticed anything else that accompanies it? Become familiar with patterns of infectious diseases that may affect your patient. Inquire about travel, contact with sick persons, and unusual exposures. Also ask about the use of any medications which may cause fever. To determine any changes in weight in the patient, you might ask,
how is your weight compared to a year ago? Why do you think your weight has changed? What would you like to weigh?
If weight gain or loss appears to be a problem, ask about the amount of change, its timing, the setting in which it occurred, and any associated symptoms. Weight gain can reflect caloric intake or accumulation of body fluids. By eliciting the patient's concerns before the examination, you prepare for an examination that is focused, efficient, and productive. With the patient's health history in mind, and after good hand hygiene, you are ready for the general survey. Through study and repetition, the examination will flow more smoothly, and your technique will become more proficient. Typically, the physical examination begins with the general survey of the patient. This includes apparent state of health based on observations throughout your encounter, level of consciousness, is the patient awake, alert, and responsive to you and others, signs of distress, does the patient show evidence of cardiac or respiratory difficulties, pain, anxiety, or depression. Check for changes in skin color and any obvious lesions. Look for scars, plaques, or nevi. Consider whether the patient's personal hygiene and grooming seem appropriate to his or her lifestyle, age, occupation, and stage of life. Keep in mind that these norms vary widely. But evaluate if the patient's clothing is appropriate to the setting and for the weather. For example, are the shoes run down with cutouts or holes leading to painful feet? Note the patient's hair, fingernails, and use of cosmetics, if any. They may be clues to the patient's personality, mood, and self-regard. Observe the patient's facial expression at rest, during conversation, and during the physical examination. Watch for eye contact and evaluate if it is natural, sustained, or unblinking. Or is the gaze averted quickly? Is the affect flat, suggesting depression? Odors, such as the fruity odor of diabetes or the scent of alcohol, can be important diagnostic clues. However, never assume that alcohol is the sole or even the most important cause of changes in mental status or neurologic findings. Does the patient walk smoothly, with comfort, self-confidence, and balance? Note the patient's preferred posture and whether the patient is restless or quiet. How often does the patient change position? Is there any apparent involuntary motor activity, or are any limbs immobile? If possible, measure the patient's height with the patient in stocking feet. Take this opportunity to note general body proportions and look for any deformities, such as kyphosis or scoliosis. Whenever possible, weigh your patients with their shoes off. Make note of any weight changes over time. Use your measurements of height and weight to determine the body mass index, or BMI. There are several ways to establish the BMI. Your electronic medical record software may do this automatically, or you may use a BMI table. The BMI is calculated by relating height, in the column on the left, to weight, indicated in the corresponding rows to the right. If the BMI is 35 or greater, measure the patient's waist circumference just above the hips. Risk for diabetes, hypertension, and cardiovascular disease increases significantly if the waist circumference is 35 inches or more in women and 40 inches or more in men. If the BMI is above 25, assess the patient for the additional risk factors noted here. Hypertension, high LDL cholesterol, low HDL cholesterol, high triglycerides, high blood glucose, family history of premature heart disease, physical inactivity, cigarette smoking. Patients with a BMI over 25 and 2 or more of these risk factors should pursue weight loss, especially if the waist circumference is elevated, seen in metabolic syndrome. Additionally, you should assess dietary intake by taking a diet history and assessing the patient's eating patterns. Assess the patient's motivation to make lifestyle changes that promote weight loss. Be prepared to provide counseling about nutrition and exercise by being well informed about strategies that promote weight loss. If the patient's BMI falls below 18.5, investigate possible anorexia, bulimia, or other serious medical conditions. Throughout the general survey, you should strive to continually sharpen your observations and your ability to describe all the distinguishing features of the patient's general appearance. Your description should be so precise that a colleague should be able to identify the patient out of a crowd of strangers. Now you are ready to measure the vital signs, which include blood pressure, heart rate, respiratory rate, and temperature. Note that recent evidence suggests that home and ambulatory blood pressure measurements are more accurate than manual measurements taken in the office. These studies propose that automated office blood pressure devices that take and average the results of 5 or more readings help eliminate observer error and minimize white coat hypertension caused by patient anxiety. Make sure the examining room is quiet and comfortably warm, and before assessing the patient's blood pressure, take these steps to make sure the measurement will be accurate. Ask the patient to avoid drinking caffeinated beverages or smoking for 30 minutes and to rest for at least 5 minutes before the blood pressure is taken. Check to make sure the selected arm is free of clothing. There should be no arteriovenous fistulas for dialysis, scarring from prior brachial artery cut-downs, or signs of lymphedema. Palpate the brachial artery to confirm that it has a viable pulse. Position the arm so that the brachial artery at the antecubital crease is at heart level, roughly level with the fourth interspace at its junction with the sternum. The patient's arm should be supported at the mid-chest level. To measure blood pressure accurately, you must choose a cuff of appropriate size. Cuffs that are too wide or too narrow may give false readings. Here are some guidelines to help you select the correct blood pressure cuff. The width of the inflatable bladder of the cuff should be about 40% of upper arm circumference, which is about 12 to 14 centimeters in the average adult. The length of the inflatable bladder should be about 80% of upper arm circumference, which is almost long enough to encircle the arm. All blood pressure devices, whether aneroid, electronic, or hybrid, should be routinely calibrated for accuracy using international protocols. To accurately measure the blood pressure, center the inflatable bladder over the brachial artery with the arm at heart level. The lower border of the cuff should be about 2.5 centimeters above the antecubital crease. Secure the cuff snugly and position the patient's arm so that it is slightly flexed at the elbow. When using an aneroid instrument, hold the dial so that it faces you directly. To determine how high to raise the cuff pressure, first estimate the systolic pressure by palpation. As you feel the radial artery with the fingers of one hand, rapidly inflate the cuff until the radial pulse disappears. Read this pressure on the manometer and add 30 millimeters of mercury to it. Using this target for subsequent inflations prevents discomfort from unnecessarily high cuff pressures. It also avoids the occasional error caused by an auscultatory gap, a silent interval that may be present between the systolic and the diastolic pressures. Deflate the cuff promptly and wait 15 to 30 seconds. Now place the bell of a stethoscope lightly over the brachial artery, taking care to make an air seal with its full rim. Because the sounds to be heard, that is, the Korotkov sounds, are relatively low in pitch, they are generally heard better with the bell. Inflate the cuff rapidly again to the level just determined, and then deflate it slowly at a rate of about 2 to 3 millimeters of mercury per second. Note the level at which you hear the sounds of at least 2 consecutive beats. This is the systolic pressure. Continue to lower the pressure slowly until the sounds become muffled and then disappear. To confirm the disappearance of sounds, listen as the pressure falls another 10 to 20 millimeters. The disappearance point, usually only a few millimeters of mercury below the muffling point, provides the best estimate of true diastolic pressure in adults. Read both the systolic and the diastolic levels to the nearest 2 millimeters of mercury. Wait 2 or more minutes and repeat the entire sequence. Average your readings. If the first 2 readings differ by more than 5 millimeters of mercury, take additional readings. Avoid slow or repetitive inflations of the cuff because the resulting venous congestion can cause false readings. Blood pressure should be taken in both arms at least once. Normally, there may be a difference in pressure of 5 millimeters of mercury and sometimes up to 10 millimeters. Subsequent readings should be taken on the arm with the higher pressure. Averaging several blood pressure measurements is best. Differences of more than 10 millimeters of mercury between the arms raise concerns of subclavian steel and aortic dissection. In 2003, the Joint National Committee on Detection, Evaluation, and Treatment of High Blood Pressure recommended using the mean of 2 or more properly measured blood pressure readings taken on 2 or more office visits for diagnosis of hypertension. For adults, the committee has defined 4 levels of systolic and diastolic hypertension: normal, prehypertension, stage 1 hypertension, and stage 2 hypertension. Note that either component may be high. When the systolic and diastolic levels fall in different categories, you should use the higher category. If you read low levels of blood pressure, you should interpret this reading in the light of past readings and the patient's clinical state. If indicated, assess orthostatic hypotension, common in older adults, by measuring blood pressure and heart rate in 2 positions: supine, after the patient is resting, from 3 to 10 minutes, and then within 3 minutes after the patient stands up. Orthostatic hypotension is a drop in systolic blood pressure of 20 millimeters or greater, or in diastolic blood pressure of 10 millimeters or greater within 3 minutes of standing, or a rise in heart rate of more than 20 beats per minute. If there are weak or inaudible Korotkov sounds, check the placement of your stethoscope and whether you have full skin contact with the bell. Also consider the possibility of venous engorgement of the patient's arm from repeated inflations of the cuff, or even the possibility of shock. To intensify Korotkov sounds, try raising the patient's arm before and while you inflate the cuff, then lower the arm and determine blood pressure. Or inflate the cuff and ask the patient to make a fist several times, and then determine the blood pressure. For the obese arm, use a cuff 15 centimeters in width, or consider using a thigh cuff wrapped around the forearm, then assessing the radial pulse. When assessing the heart rate, or HR, the radial pulse is commonly used. With the pads of your index and middle fingers, compress the radial artery until you detect a maximal pulsation. If the rhythm is regular and the rate seems normal, count the rate for 30 seconds and multiply by 2. If the rate is unusually fast or slow, however, count it for 60 seconds. The range of normal is 50 to 90 beats per minute. To begin your assessment of rhythm, feel the radial pulse. If there are any irregularities, check the rhythm again by listening with your stethoscope at the cardiac apex. Premature beats may not be detected peripherally, and the heart rate can be seriously underestimated. Is the rhythm regular or irregular? If irregular, try to identify a pattern by asking, do early beats appear in a basically regular rhythm? Does the irregularity vary consistently with respiration? And is the rhythm totally irregular? Always check an electrocardiogram if the rhythm is irregular to identify which type of rhythm is present. Next, observe the rate, rhythm, depth, and effort of breathing. Count the number of respirations in 1 minute, either by visual inspection or by subtly listening over the patient's trachea with your stethoscope during your examination of the head and neck or chest. Normally, adults take approximately 20 breaths per minute in a quiet, regular pattern. An occasional sigh is normal. Check to see if the expiration is prolonged, suggesting COPD. For oral temperatures, choose either a glass or electronic thermometer. When using a glass thermometer, shake the thermometer down to 35 degrees Celsius or 96 degrees Fahrenheit or below. Then insert it under the tongue, instruct the patient to close both lips, and wait 3 to 5 minutes. Then read the thermometer, reinsert it for 1 minute, and read it again. If the temperature continues to rise, repeat the procedure until the reading remains stable. Note that hot or cold liquids, or even smoking, can alter the temperature reading. So in these cases, it is best to delay measuring the temperature for 10 to 15 minutes. Electronic thermometers are increasingly replacing glass thermometers. To use this device, carefully place the disposable cover over the probe. Insert the thermometer under the tongue and ask the patient to close both lips, and then watch closely for the digital readout. An accurate temperature recording usually takes about 10 seconds. Most patients prefer oral to rectal temperatures. However, taking oral temperatures is not recommended if patients are unconscious, restless, or unable to close their mouths. In these cases, rectal temperatures are advised. For a rectal temperature, ask the patient to lie on one side with the hip flexed. Lubricate the tip of the thermometer. Insert the thermometer about 3 to 4 centimeters, or 1.5 inches, into the anal canal in a direction pointing to the umbilicus. Remove it after the recommended time period, then read. As opposed to this electronic thermometer, the process with a glass thermometer is the same, although you must wait 3 minutes to read the results. Taking the tympanic membrane temperature is an increasingly common practice and is quick, safe, and reliable if performed properly. Make sure the external auditory canal is free of cerumen, which lowers the temperature readings. Position the probe in the canal so that the infrared beam is aimed at the tympanic membrane, otherwise the measurement will be invalid. Wait 2 to 3 seconds until the digital temperature reading appears. This method measures core body temperature, which is higher than the normal oral temperature by approximately 0.8 degrees Celsius or 1.4 degrees Fahrenheit. Normal oral temperature in adults fluctuates considerably, with the average usually quoted as 37 degrees Celsius or 98.6 degrees Fahrenheit. It may fall as low as 35.8 degrees Celsius in the morning hours, or rise as high as 37.3 degrees Celsius in the late afternoon or evening. Rectal temperatures are higher than oral temperatures by an average of 0.4 to 0.5 degrees Celsius or 0.7 to 0.9 degrees Fahrenheit. This difference, too, is quite variable. In contrast, axillary temperatures are lower than oral temperatures by approximately 1 degree, take 5 to 10 minutes to register, and are generally considered less accurate than other measurements. Many now consider pain the fifth vital sign. Adopt a comprehensive approach to understanding any pain the patient may report, listening carefully to the patient's description of the many features of pain and its contributing factors. Accept the patient's self-report, which experts state is the most reliable indicator of pain. Ask the patient to point to the pain, because patients often cannot describe or localize the site of origin. Ask the patient to describe the pain and how it started, and whether it is related to a site of injury, movement, or time of day. Identify the 7 features of the patient's pain. Also ask about the quality of the pain, sharp, dull, or burning. Ask if the pain radiates or follows a particular pattern. Ask what makes the pain better or worse. Assessing the severity of pain is especially important, and there are many scales at your disposal to help determine that, which can be used by children as well as patients with language barriers or cognitive impairment. Managing pain is a complex clinical challenge, and treatment should be multidimensional. You should strive to attain an in-depth knowledge of analgesics and behavioral and physical therapy, as well as the risk factors of possible treatments. Remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
Patient is of medium height and weight who appears well-groomed and has mobility issues. He is pleasant and cooperative during the examination. Weight is 220 pounds.
After practice and further review of this video, make sure you have mastered the important learning objectives for the general survey of your patient.
Good morning, Mr. Morris.
Good morning.
Typically, you will perform a comprehensive physical examination on new patients or patients being admitted to the hospital. This provides fundamental knowledge about the patient and helps identify or rule out physical causes related to your patient's health concerns. A skilled head-to-toe examination of adult patients requires a thorough knowledge of the techniques of examination for each region of the body. You should be prepared to detect normal variations and abnormal findings. The patient's health and well-being should be the primary focus of the examination, but you must promote the patient's personal comfort as well. Take time to adjust the examining room's environment prior to the examination, making changes in lighting, sound, or privacy, for example. By demonstrating respect for the patient, you promote the patient's comfort and relaxation, which helps ensure a successful examination. Another key to patient comfort is your attention to proper draping during the examination, combined with communication about your intentions as you move from one regional examination to the next. Your patients will appreciate knowing why you are adjusting their gown or causing them even minor discomfort. Minimize the number of times you ask the patient to change positions, from sitting to supine or from supine to standing, for example, to assure patient comfort. Developing a systematic sequence of examination greatly aids your ability to conduct an accurate physical examination with thoroughness and efficiency. With experience, you will acquire a routine that works well for you and for the patient. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. For a healthy patient, a complete head-to-toe assessment should take beginning students about 20 to 30 minutes. With the patient sitting, begin your assessment with a general survey, inspecting the patient closely, literally from head to toe, in order to form impressions for your later written assessment. Note characteristics such as apparent state of health, ease of breathing, height, build, and sexual development. Obtain the patient's weight. Note posture, motor activity, and gait, as well as dress, grooming, personal hygiene, and any odors of the body or breath.
Okay, very good. So,
Observe the patient's facial expressions and listen to the patient's manner of speaking as you note his or her state of awareness. Now measure vital signs. When measuring blood pressure, select a cuff of the appropriate size and position the patient's arm properly at heart level. This will help ensure an accurate reading. Record the patient's heart rate by checking the radial or, in older adults, the apical pulse. Next, check respiration. Listen to the number of respirations per minute by subtly placing the stethoscope over the patient's trachea. Next, check the patient's temperature. 3 methods are commonly used: oral, via the tympanic membrane, or at times rectal. Oral temperatures are the most common, but should not be used for patients who are unconscious, restless, or unable to close their mouths. Begin inspection of the patient's skin by observing the patient's face. Assess the facial expression, skin moisture or dryness, any facial swelling or asymmetry, and check for any cyanosis in the lips. Inspect and palpate the patient's fingernails, looking especially for any clubbing or cyanosis. Continue your assessment of the skin as you examine the other body regions. Note color, pigmentation, texture, hair distribution and thickness, and any lesions. Look for nevi, scars, or other distinguishing characteristics, noting their placement and dimensions. When you see nevi or moles, assess for melanomas using the ABCDE method. Inspect for asymmetry, irregular borders, color variation or change, especially blue or black, diameter larger than 6 millimeters, and elevation. If any of these 5 aspects is present, consider referring the patient to a dermatologist for further evaluation. In sun-exposed areas, flaking ulcerated lesions are suspicious for a squamous cell carcinoma and shiny raised lesions for a basal cell carcinoma. Next, assess the head, eyes, ears, nose, and throat. Palpate the scalp, looking for any depressions of the skull, which might indicate head trauma or previous surgery. Inspect the hair and its texture, looking for nevi, lesions, or even lice. Inspect the face. Note whether the facial expressions and eyebrows are symmetric.
So I'm going to turn the lights out and we're going to check your pupils, okay?
Check the color of the conjunctiva and sclera, looking for pallor in the conjunctiva or icterus in the sclera. Inspect each cornea, iris, and lens, noting any injection of the cornea, especially around the iris. Compare the pupils and test their reactions to light and accommodation. With an ophthalmoscope, inspect the ocular fundi, checking carefully for sharpness of the disc margins and especially any blurring of the margins, suggesting papilledema, shown here. Next, examine the ear canal and drum using your largest ear speculum and holding the otoscope at an upward angle. Check auditory acuity. If acuity is diminished, check lateralization using the Weber test, and compare air and bone conduction with the Rene test. Next, inspect the anterior and inferior surfaces of the nose. Note any asymmetry or deformity. Then, inspect the inside of the nasal passages with an otoscope. Palpate for sinus tenderness by pressing up on the frontal sinuses from under the bony brows, then press up on the maxillary sinuses.
Okay, I'm going to check your mouth, your lips.
Inspect the mouth, observing the symmetry, color, and moisture of the lips, and note any masses, ulcers, cracking, or scaliness. Inspect the oral mucosa and note the color of the gums, normally pink. Inspect the gum margins and the interdental papillae for swelling or ulceration. Inspect the patient's teeth and look for abnormalities. Inspect the hard and soft palates, the uvula, tongue, and other structures of the mouth. Pay particular attention to the floor of the mouth and the sides and undersurface of the tongue, for here is where leukoplakia or cancers can develop. Next, you may wish to perform a brief assessment of the 12 cranial nerves while the patient is sitting and facing you. Cranial nerve 1, the olfactory nerve, is typically not tested unless a neurological problem is suspected. In the head-to-toe assessment, cranial nerve 2, the optic nerve, can be assessed with a test for visual acuity by using a Snellen eye chart. Pupillary response was tested earlier. Cranial nerves 3, 4, and 6 control extraocular movement.
All right, I'd like you to look straight ahead, just right over my shoulder, and then I want you to follow my finger, okay? Excellent.
Next, test for the several components of cranial nerve 5, which includes motor response, sensory response, and the corneal reflex.
All right, I'd like you to just clench your jaw for me. Okay, very good. And then I'm just going to check sharp and dull.
Okay.
So tell me if you're feeling anything brush your skin. Just say yes or no.
Yes.
Cranial nerve 7 is assessed by inspecting the patient's movements of facial expression.
Raise your eyebrows for me. Good. And relax. Squeeze your eyes tight shut. Good. And puff your cheeks. Relax. And show me your teeth. Excellent.
Next, assess cranial nerve 8, which is responsible for hearing. Test one ear at a time.
I'm going to whisper in your ear and tell me what you hear.
21.
Excellent.
14.
Very good.
Assess cranial nerves 9 and 10 by listening to the patient's voice. Is it hoarse, or does it have a nasal quality?
Open your mouth.
Here, you'll also ask the patient to say ah, or to yawn as you watch for symmetric movement of the soft palate, uvula, and the interior and posterior pillars and pharynx. For cranial nerve number 10, warn the patient that you are going to test the gag reflex. Then, stimulate the back of the throat lightly on each side in turn. Assess cranial nerve 11 from behind the patient. Look for atrophy or fasciculations in the trapezius muscles. Ask the patient to shrug both shoulders upward against your hands. Note the strength of the trapezius. From the front, ask the patient to turn his head to each side against your hand. Observe the contraction and force of the opposite sternomastoid and note the force of the movement against your hand. Assess the 12th cranial nerve by inspecting the patient's tongue for atrophy or fasciculations.
All right, I'd like you to stick out your tongue for me.
Then, with the patient's tongue protruded, look for asymmetry and deviation from the midline. Once you have completed any assessment of the 12 cranial nerves, inspect the neck by palpating the anterior and posterior cervical lymph nodes. For each node, note its size, mobility, and any tenderness. Note any masses or unusual pulsations in the neck. Next, palpate in the sternal notch to check the position of the trachea. It should be midline. Ask the patient to take a sip of water and inspect for the thyroid gland as the patient tips his head back, then swallows.
Just hold it in your mouth. Okay.
From in front of the patient, inspect and palpate the region below the cricoid cartilage for the thyroid isthmus and for any glandular enlargement.
You can lower your head. I'm just going to feel for the...
Repeat, standing behind the patient. Position behind the patient. Continue by inspecting the muscles of the upper back. Observe shoulder height for symmetry. Then, palpate the spine and muscles of the upper back.
Check your spine. Any soreness there or tenderness?
No, it's fine.
Inspect, palpate, and percuss the chest and lungs. Percuss the lungs in a ladder pattern, going from side to side as you move down the thorax, from the apices to the basis of the lungs. Normal lungs are resonant. Locate any areas where you hear abnormal notes. Next, use percussion to identify the level of diaphragmatic dullness and measure descent of the diaphragm. To assess respiratory excursion, place your thumbs close to the patient's spine at the level of the 10th ribs and spread your hands lightly over the lower thorax. Ask the patient to inhale deeply and exhale fully while you watch the divergence of your thumbs and feel for the range and symmetry of movement of the thorax. Using the diaphragm of the stethoscope, observe the rate, rhythm, depth, and effort of breathing, and listen for adventitious sounds that may indicate abnormal respiratory conditions. Listen to at least one entire breathing cycle at each location, including over the right middle lobe under the axilla. Once you have already examined the patient's hands and upper back, you may decide, based on your observations, that a more extensive musculoskeletal examination is warranted. If so, while the patient remains sitting upright, inspect and palpate the temporomandibular joints, hands, wrists, elbows, shoulders, and neck. Inspect and palpate the joints, then check their range of motion. For the shoulders, assess external and internal rotation. With the patient still seated, you can perform a neurological examination of the patient's upper extremity. First, visually assess the patient's muscle bulk, then check muscle tone. Now test muscle strength. Ask the patient to squeeze your fingers as hard as he can. Next, test the patient's biceps. Then test the triceps and repeat on the other side.
Okay, with your eyes open, touch my finger.
Next, check for point-to-point movement
And now again. Good.
and assess rapid alternating movements. Together, these exercises help you assess the patient's upper extremity strength and coordination.
Excellent.
Examination of the breasts is important for both female and male patients. While the techniques of examination for men and women patients are similar, the female breast is usually more dense, and its examination should therefore be more thorough. Palpate in a smooth rotary motion, assessing the breast tissue for consistency, tenderness, and nodules or masses. In the woman, to begin the examination, visually inspect the breasts with the patient seated and her arms at her sides. Inspect the breasts with her arms raised and with her hands placed on her hips. In either sex, inspect the axillae and feel for the axillary nodes. Feel for the epitrochlear nodes as well. Although examination of the male breasts may be brief, it should not be omitted. Inspect for symmetry and size, and palpate each nipple, areola, and breast for nodules. To examine the anterior thorax, have the patient remain supine and breathing normally. Observe the condition of the skin and inspect the chest for deformities, asymmetry, and respiratory movement. Next, palpate the chest wall to locate any areas of tenderness or to assess any lesions or abnormalities. Next, percuss the anterior thorax in symmetrical areas, proceeding from the supraclavicular area down to the sixth rib or below. Again, compare both sides. Identify your percussion notes and their locations. Using the diaphragm of your stethoscope, you should hear breath sounds over the anterior lung fields. With the patient supine and elevated to a 30-degree angle, begin the cardiac examination.
And relax.
Often, the first step in your cardiovascular assessment is estimating the jugular venous pressure, or JVP. Measure the JVP in relation to the sternal angle. Next, inspect and palpate the carotid pulsation. This will include both palpation and listening for bruits. Inspect and palpate the precordium. Note the location, diameter, amplitude, and duration of the apical impulse. Listen at each auscultatory area in 6 positions. Start with the diaphragm of the stethoscope at the right upper sternal border and the left upper sternum. Listen at the left lower sternal border and the apex with the bell. S1 is louder at the apex and S2 is louder at the base. Listen for physiologic splitting of S2 at the upper left sternal border. Also listen for any abnormal heart sounds or murmurs. Lower the table flat. Expose the supine patient's abdomen, draping the lower abdomen at the suprapubic level. First, listen for active bowel sounds.
And listen to your abdomen.
palpate lightly, then deeply. Assess the liver and spleen by percussion and then palpation. Try to feel the kidneys and palpate the aorta and its pulsations. Examine the peripheral vascular system by palpating the femoral pulses, then the popliteal pulses. Palpate the inguinal lymph nodes. Inspect for lower extremity edema, discoloration, or ulcers. Palpate for pitting edema. Assess the pedal pulses. With the patient standing, inspect for any varicose veins. With the patient remaining supine, you may wish to complete the musculoskeletal examination. Examine the hips, legs, knees, ankles, and feet. Inspect and palpate these areas for tenderness, deformities, nodules, swelling, corns, or calluses. To complete the neurological examination, assess lower extremity strength, bulk, tone, sensation, reflexes, and Babinski's to complete your examination of the nervous system. Inspect the patient's musculoskeletal system, both supine and standing. With the patient standing, examine the alignment of the spine and its range of motion, as well as the alignment of the legs and feet. Observe the patient's gait and ability to walk heel to toe and walk on the toes, the heels, hop in place, and do shallow knee bends. Do a Romberg test and check for pronator drift. A complete examination of the nervous system can be done at this point, if not done earlier. It consists of 5 segments: mental status, cranial nerves, motor system, sensory system, reflexes. The mental status is determined by assessing the patient's orientation, mood, thought process, and content, abnormal perceptions, insight, and judgment. As previously outlined, the 12 cranial nerves may be examined here. The motor system consists of examination of muscle bulk, tone, and tests of strength of major muscle groups of the upper and lower extremities. Assessment of the sensory system evaluates pain and, if indicated, temperature, light touch, vibration, proprioception, and discrimination. Test the reflexes of biceps, triceps, brachioradialis, patellar, and Achilles deep tendon reflexes and the Babinski's. Genital and rectal examinations are often performed at the end of the head-to-toe examination. An examination of male patients begins with inspection of the genitalia, continues with inspection of the sacrococcygeal and perianal areas, and includes palpation of the anal canal, rectum, and prostate. Genital and rectal examinations of female patients begin with inspection of the external genitalia and continues with a speculum examination of the vagina and cervix, including a pap smear and cultures if indicated. The clinician may also perform a bimanual examination of the uterus and adnexa, followed by the rectovaginal and rectal examinations if indicated. Pay particular attention to draping during these examinations, and whenever possible, continue to minimize the patient's exposure. Remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
The patient is of medium height and weight, middle-aged, and responds well to questions. He is relaxed, his skin is warm and moist. He is well-groomed, his color is...
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the patient head to toe. The more adept you are at the principles of clinical reasoning, patient interviewing, and therapeutic support, the more effective your physical examination will be to the well-being of your patient. Your learning objectives for mastering the examination of the sensory system and reflexes are to assess pain, temperature, light touch, and vibratory sensations, as well as position sense and discriminative sensation, and to correctly elicit the deep tendon reflexes of the biceps, triceps, brachioradialis, knee or patellar tendon, and ankle or Achilles tendon, as well as to properly test the plantar response or Babinski sign. Sensory impulses participate in reflex activity and give rise to conscious sensation, calibrate body position in space, and help regulate autonomic functions such as blood pressure, heart rate, and respiration. A complex system of sensory receptors relays impulses from skin, mucous membranes, muscles, tendons, and viscera that travel through peripheral projections into the posterior root ganglia and are eventually directed to the spinal cord and into the brain. When testing sensation, use a symmetric pattern on both sides of the body. Comparison helps you to better identify where sensory losses occur. By identifying the distribution of sensory abnormalities and the kinds of sensations affected, you can infer the location of causative lesions. To help localize neurologic lesions, the body is commonly mapped into dermatomes, which are skin bands innervated by the sensory root of a single spinal nerve. It is helpful to familiarize yourself first with the dermatome shaded in green. For example, T4 at the nipple line, T10 at the umbilicus, and L5 at the anterior ankle and foot. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. Begin the sensory examination by assessing pain sensation in arms, legs, and trunk. To do this, first warn the patient, then use the sharp end of a broken cotton swab stick, a previously unused safety pin, or some other suitable tool. Ask the patient to close his eyes, then, starting with the arms, test scattered areas in a symmetric pattern on both sides of the body, occasionally substituting the blunt end for comparison between sharp and dull. Discard the broken swab after using it. Temperature testing is performed when pain sensation is abnormal. Use 2 test tubes filled with hot and cold water.
I got 2 test tubes here. That one's cold and that one's hot.
Okay.
Now you close your eyes. Now tell me which it is.
Cold. Hot. Hot. Cold. Hot. Cold.
Next, assess light touch with a cotton wisp. In diabetics, watch for the stocking glove pattern of sensory peripheral neuropathy.
Now I'm going to touch you with this cotton wisp. Whenever you feel it, you say now.
Okay.
Close your eyes.
Now. Now.
Next, assess vibratory sensation using a lightly vibrating low-pitched tuning fork. Have the patient close his eyes. Tap the tuning fork on the heel of your hand and place it against the soft distal tissue of the finger and large toe and ask the patient to tell you what he feels. Ask the patient to tell you when the sensation stops.
What do you feel?
The same thing.
Okay, tell me when it stops.
Then move the tuning fork closer to the trunk to see if it is perceived. Even in normal patients, some slight distal to proximal gradient may be found. Vibratory sense is often impaired in alcoholic peripheral neuropathy. To test position sense, or proprioception, hold the sides of the patient's big toe with your thumb and index finger. Avoid touching the other toes. Next, ask the patient to close his eyes and identify the direction of motion. Repeat several times on each side in an irregular sequence. Then
You ready?
compare with the big
Here it
toe on
comes.
the other foot.
Up.
Again, with the patient's eyes closed, test position sense in the upper extremities, beginning with a finger on each of the patient's hands and moving more proximally to the metacarpophalangeal joints and beyond if indicated.
Here it comes.
Up. Down.
Finally, test discriminative sensations, beginning with stereognosis, the ability to identify an object by feeling it. Ask the patient to close his eyes, then place a familiar object in the palm and ask the patient to identify it.
Small coin.
Repeat the procedure on the other hand, using a different sized coin or a different
A
object.
bigger coin?
Not the same as the other hand?
No, it's bigger.
Okay.
To test graphesthesia, or number identification, ask the patient to close his eyes and use a blunt object to draw a large number on the palm.
What was that?
5.
Using two ends of an opened paper clip or the ends of two pins, repeatedly touch the patient's finger pad with the 2 points at the same time and with 1 point occasionally. Be careful not to cause pain. Ask the patient to identify if he's being touched with 1 or 2 points.
1.
Then reduce the distance between the points so that you can determine the minimum distance at which the patient can identify 2 points. On the finger pad, the distance should be less than 5 millimeters.
2.
Good.
To test point localization, ask the patient to keep the eyes closed. Then touch a point on the patient's skin. Ask him to open his eyes and point to the place touched.
All right, close your eyes. Here comes the first one.
This test is especially helpful for locating sensory loss on the trunk and legs. To test double extinction, use your fingertips to provide stimulus in either one area of the patient's body or in 2 areas simultaneously.
Are you ready?
Normally, the patient should be able to identify whether your stimulus was on one side or on both sides.
Both.
Before we assess the deep tendon reflexes, let's see how and where they occur. Deep tendon reflexes are involuntary monosynaptic cord reflexes arising from the stimulation of partially stretched muscle fibers. This sudden additional stretching sends impulses along afferent sensory nerve fibers to synapses in the spinal cord. Then efferent nerve fibers carry the impulses back to the muscle fibers, causing them to contract. Interruption of these monosynaptic arcs anywhere along their paths will cause loss of reflex. Each deep tendon reflex corresponds to a specific spinal segment. The ankle reflex primarily relates to S1 and L5. The knee reflex to L2, L3, and L4. The brachioradialis to C5 and C6. The biceps reflex also to C5 and C6. And the triceps reflex to C6 and C7. Note the ascending order of the numerical sequence from ankle to triceps, a tip for helping you remember the reflex innervations. When assessing deep tendon reflexes, grade them on a scale from 0 to 4+. A grade of 0 reflects no response. 1+ indicates a somewhat diminished reflex. A 2+ reflex shows greater movement than 1+ and is the average normal response. A 3+ reflex is brisker than average, but is still normal. A 4+ reflex is a very brisk hyperactive response. By definition, it must be accompanied by clonus, a rhythmic oscillation between flexion and extension. Begin assessing deep tendon reflexes by testing the biceps reflex. The patient's arm must be relaxed, partially flexed at the elbow, and positioned with the palm down. Depress the biceps tendon with your thumb or index finger. Strike your thumb or finger briskly with the reflex hammer. You should feel the biceps muscle contract and see flexion of the forearm. To assess the triceps reflex, flex the patient's arm at the elbow with the palm toward the body and pull the arm slightly across the chest. Strike the triceps tendon above the elbow. Watch for contraction of the triceps muscle and extension at the elbow. To elicit the supinator or brachioradialis reflex, the patient's forearm should rest on the abdomen or lap with the forearm partly pronated. When the patient is ready, strike the radius 1 to 2 inches above the wrist. Observe for flexion and supination of the forearm. To test the knee reflex, locate the patellar tendon with the patient's knee flexed. Briskly tap the tendon just below the patella. Note contraction of the quadriceps and look for quick extension of the knee. A hand on the anterior thigh lets you feel this reflex. Supporting both knees at once allows you to assess small differences between the reflexes of each knee. Test the ankle reflex. If the patient is sitting, dorsiflex the foot at the ankle. Ask the patient to relax and strike the Achilles tendon. Watch for the plantar flexion at the ankle and note the speed of relaxation after the muscular contraction. If the patient is lying down, flex one leg at both hip and knee and rotate it externally so that the lower leg rests across the opposite shin. Then, dorsiflex the foot at the ankle and strike the Achilles tendon. Repeat this test on the opposite side. If the knee and ankle reflexes seem hyperactive, test for ankle clonus. Support the knee in a slightly flexed position. With your other hand, dorsiflex and plantar flex the foot a few times, and then sharply dorsiflex the foot and maintain it in dorsiflexion. Look and feel for sustained rhythmic oscillations between dorsiflexion and plantar flexion. In most normal people, the ankle does not show clonus. A few clonic beats may be seen and felt, especially when the patient is tense or has exercised. Now turn to the cutaneous stimulation reflexes. To test these reflexes, lightly but briskly stroke each side of the abdomen from above T8 to 10 and below T10 to 12, the umbilicus. You should see contraction of the abdominal muscles and sometimes deviation of the umbilicus toward the stimulus. To test for plantar response, use an object such as the wooden end of an applicator stick or the handle of your reflex hammer to stroke the lateral aspect of the sole of the foot from the heel to the ball, curving medially across the ball. Warn the patient that this stimulus may feel uncomfortable. Use the lightest stimulus that will provoke a response. Note this patient's normal response, plantar flexion or downgoing of the big toe. Some patients withdraw from the stimulus by flexing the hip and the knee. Hold the ankle if necessary to complete your observation. It is sometimes difficult to distinguish withdrawal from a Babinski response. Dorsiflexion of the big toe, or a positive Babinski's sign, is a pathological response, which, as simulated here, manifests itself in dorsiflexion or upgoing of the big toe in conjunction with fanning of the other toes. A positive test indicates a corticospinal tract lesion seen in a stroke. If you suspect meningeal inflammation, test for meningeal signs. First, make sure there is no injury to the cervical vertebrae or cervical cord. With the patient lying down, place your hands behind the patient's head and flex the neck forward until the chin touches the chest if possible. There should be no resistance or pain. As you flex the patient's neck, watch his hips and knees. Normally, they should remain relaxed and motionless. Hip and knee flexion with this maneuver is a positive Brudzinski sign. Flex one of the patient's legs at the hip and knee and then straighten the knee. This action normally produces discomfort behind the knee during extension, but should not cause pain. Pain and resistance to knee extension is a positive Koenig sign. For low back pain with nerve pain that radiates down the leg, commonly called sciatica, in the S1 distribution, test straight leg raising for lumbosacral radiculopathy. Raise the supine patient's relaxed and straightened leg, flexing the leg at the hip, then dorsiflex the foot at an angle of about 60 degrees. Radicular pain into the leg constitutes a positive test. Do not mistake normal tightness or discomfort in the buttocks or hamstring muscles as a positive test. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
Sensory. Pinprick, light touch, position and vibration intact. Reflexes. 2+ and symmetric with plantar reflexes downgoing.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the patient's neurosensory system.
So, what brought you over to see me today?
Your learning objectives for mastering the examination of the cranial nerves and motor system are: review the 3 important principles guiding the neurologic examination, being: is the mental status intact? Are right-sided and left-sided findings symmetric? If the findings are asymmetric or otherwise abnormal, does the causative lesion lie in the central nervous system or in the peripheral nervous system? Identify and test the integrity of the 12 cranial nerves. Master testing of the motor system, especially muscle strength, but also movement, bulk, tone, and cerebellar function. Learn to grade muscle strength. Note that cerebellar function includes rapid alternating movements of the arms and legs, point-to-point movements from finger to nose and heel to shin, and gait. By eliciting the patient's concerns before the examination, you prepare for an examination that is efficient and productive. Common or concerning symptoms relating to the nervous system include headache, dizziness or vertigo, generalized proximal or distal weakness, numbness and abnormal or loss of sensation, loss of consciousness, fainting or syncope, seizures, tremors, and involuntary movements. In clinical practice, a neurologic examination begins with an assessment of mental status. Specifically, now is a good time to observe the patient's appearance and behavior, speech and language, mood, memory, and orientation. Please refer to Chapter 5, Behavior and Mental Status in Bates' 11th edition for an in-depth discussion of formal testing of mental status. Let's briefly review the location of the cranial nerves within the peripheral nervous system. The peripheral nervous system consists of both cranial nerves and the peripheral nerves projecting from the spinal cord. 12 pairs of cranial nerves emerge from within the skull and mediate complex motor and sensory functions. Cranial nerve 1 and 2 are actually fiber tracts emerging from the brain. Cranial nerves 3 through 7 arise from the diencephalon and brainstem. Several of the cranial nerves are specialized, producing smell, vision, or hearing. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. To examine the cranial nerves, you may begin with cranial nerve 1, the olfactory nerve, which mediates the sense of smell. If you do assess its function, first be sure each nasal passage is open by compressing one side of the nose and asking the patient to sniff through the other. With his eyes closed and one of the patient's nostrils occluded, pass a mildly aromatic and familiar substance, such as vanilla, clove, cinnamon, or coffee, under the open nostril. If the patient detects the smell, Ask him to identify it. Cranial nerve 2, the optic nerve, mediates vision. To assess its function, check the patient's visual acuity, visual fields,
Tell me when you see the finger wiggle.
and removing glasses if necessary, inspect the optic fundi of both eyes. In the fundi, be sure to inspect the ratio of the caliber of arteries to veins, usually 1 to 3, and changes in the arteries, like vascular narrowing. Also look for papilledema, pallor from optic atrophy, and any cup enlargement suggesting glaucoma. Cranial nerves 3, 4, and 6, the oculomotor, trochlear, and abducens nerves, control eye movements. Because these nerves work together so closely, they are examined as a group. Check the extraocular movements in the 6 cardinal directions of gaze, and look for conjugate movements in any of the 6 directions, which causes diplopia. Ask the patient which, if any direction, makes the diplopia worse. Inspect the eye closely for asymmetric deviation of movement. Determine if the diplopia is monocular or binocular by asking the patient to cover one eye or perform the cover-uncover test. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of his nose. Eyes can usually follow your finger to within 5 to 8 centimeters. Identify any nystagmus, an involuntary jerking of the eyes with quick and slow components. Note the direction of the gaze in which it appears, the plane of the nystagmus, horizontal, vertical, rotary, or mixed, and the direction of the quick and slow components. Note that nystagmus is named for the direction of the quick component. For example, right gaze nystagmus. Ask the patient to fix his or her vision on a distant object and observe if the nystagmus increases or decreases. Look for ptosis, which is drooping of the upper eyelids seen in palsy of cranial nerve 3 and myasthenia gravis. A slight difference in the width of the palpebral fissures may be normal variation in approximately 1/3 of all people. The motor portion of cranial nerve 5, the trigeminal nerve, innervates the muscles of mastication. The sensory portion of the nerve mediates facial sensation and the sensory part of the corneal reflex. To palpate the temporal and masseter muscles in turn, ask the patient to clench the teeth. Note the strength of muscle contraction. Then ask the patient to move the jaw from side to side. The sensory portion of the trigeminal nerve has 3 divisions, the ophthalmic, maxillary, and mandibular divisions. To test the sensory portion of the trigeminal nerve, explain to the patient how you will assess for pain.
That is sharp. Okay?
With the patient's eyes closed, test for pain sensation using the sterile sharp end of a broken cotton swab stick or some other suitable sharp object to stimulate the patient's forehead and cheeks at the points indicated. Occasionally, substitute the dull end for the sharp one as you test scattered areas. Compare symmetrical areas on both sides of the face. If you suspect an abnormality, confirm it by testing further for temperature sensitivity by using 2 test tubes filled with hot and cold water. A tuning fork, which usually feels cold, may also be used and made warmer by running it under hot water and drying it before use. Next, test for light touch using a wisp of cotton. Ask the patient to respond whenever you touch the skin. To test the corneal reflex, ask the patient to remove contact lenses, which frequently diminish or abolish this reflex. Prepare a fine wisp of cotton. Ask the patient to look up and away from you. Approach the patient from the side, out of his line of vision, and lightly touch the cornea with the cotton. Normally, the patient's eyes blink and tear. The sensory limb of this reflex is carried in cranial nerve 5 and the motor response in cranial nerve 7. Cranial nerve 7, the facial nerve, innervates all the muscles of facial movement and expression. It also mediates taste sensation in the anterior 2/3 of the tongue. To assess this nerve, inspect the patient's face at rest and during conversation. Note any asymmetry and look for tics or other involuntary movements. Next, ask the patient to show his teeth. Close his eyes so tightly that you can't open them.
Okay, open.
Wrinkle his forehead.
Good.
Puff out his cheeks
All right, good. Now,
and tense his neck muscles. Normally, the patient can do these maneuvers easily and symmetrically. Cranial nerve 8, the acoustic nerve, mediates hearing and vestibular function. Assess hearing with the whispered voice test.
9x1.
9x1.
If hearing loss is present, determine if the loss is conductive from impaired air-through-ear transmission or sensory neural from damage to the cochlear branch of cranial nerve 8. Test for air and bone conduction using the Weber test.
Yes.
Is it the same in both ears?
Yes.
Okay.
And lateralization using the Rene test.
Tell me when it stops.
It stopped?
Still hear it?
Yes.
Cranial nerves 9 and 10, which are the glossopharyngeal and vagus nerves, mediate the sensory and motor functions of the palate, the pharynx, and the larynx. To test these nerves, ask the patient to say ah or yawn as you observe the soft palate and the pharynx. The soft palate should rise promptly and symmetrically, and the uvula should remain midline, and each side of the posterior phalanx moves medially like a curtain. Warn the patient that you are going to test the gag reflex, which consists of elevation of the tongue and soft palate and constriction of the pharyngeal muscles. Stimulate the back of the throat lightly on each side in turn and note the gag reflex. Many normally healthy people have a diminished gag reflex. Cranial nerve 11, the spinal accessory nerve, innervates the sternomastoid and upper trapezius muscles. From behind, ask the patient to shrug his shoulders upward against your hands. During this maneuver, evaluate the strength and contraction of the trapezius muscles.
Turn your chin into my hands strong.
From in front of the patient, ask the patient to turn his head to each side against your hand. Observe the contraction of the opposite sternomastoid muscle and notice the force of the movement against your hand. Cranial nerve 12, the hypoglossal nerve, mediates the tongue's motor functions, which in turn affect articulation of words. First, listen to the articulation of the patient's words. Inspect the patient's tongue as it lies on the floor of his mouth. Observe for atrophy and fasciculations. Some coarser, restless movements are often seen in a normal tongue. Ask the patient to stick out his tongue. Note any asymmetry or deviation from the midline. Ask the patient to move the tongue from side to side and note symmetry of the movement. As you assess the motor system, focus first on body position and involuntary movements, then assess the important characteristics of the muscles, bulk, tone, and especially strength. Also assess coordination. Observe the patient's body position during movement and at rest. Watch for involuntary movements, such as tremors, tics, or fasciculations. Inspect the size and contours of the muscles. Do the muscles look flat or concave, suggesting atrophy? If so, is the atrophy unilateral or bilateral? Is it proximal or distal? Atrophy of hand muscles may occur with normal aging. When looking for atrophy, pay special attention to the hands, shoulders, and thighs. In older adults, look especially for wasting of the quadriceps, which increases risk of falls. Then evaluate the patient's muscle tone or resistance to passive stretch. Encourage the patient to relax. Take one hand in yours, and while supporting the elbow, flex and extend the patient's fingers, wrist, elbow, and put the shoulder through a moderate range of motion. On each side, note muscle tone, the resistance offered to your movements. Remember, in muscle testing, the patient resists and the examiner overcomes the patient's resistance. To assess muscle tone in the legs, support the patient's thigh with one hand, grasp the foot with the other, and flex and extend the patient's knee and ankle on each side. Note the patient's resistance to your movements. Assess both legs in turn. As you assess muscle strength, keep in mind that a person's dominant side is usually slightly stronger than the non-dominant side. You will grade your patient's muscle strength on a scale of 0 to 5, with 0 indicating no muscular contraction detected, and 5 indicating active movement against full resistance without evident fatigue. This is considered a normal response. Begin by testing flexion of the biceps muscle by having the patient bend his arm at the elbow and pull against your hand, and test extension of the triceps by having the patient push against your hand. Next, test flexion of the patient's wrist and extension of the patient's wrists. Next, test the patient's grip. Cross your middle and index fingers to cushion them and ask the patient to squeeze as hard as possible while you try to remove your fingers. Normally, you should have trouble removing them. Continue testing muscle strength by asking the patient to turn his palm down and spread his fingers. Check abduction by trying to force them together. Test opposition of the thumb by asking the patient to try to touch the tip of his little finger with his thumb while you resist the movement. This may be impaired in carpal tunnel syndrome. Examination of the motor system of the lower extremities is best performed with the patient lying supine on the examination table. Test flexion at the hip by placing your hand on the patient's thigh and asking the patient to raise the leg against your hand. Then test hip extension by the gluteus maximus by placing your hand on the patient's posterior thigh and providing resistance. To test hip abduction by the gluteus medius and gluteus minimus, place your hands firmly on the table outside the patient's knees. Ask the patient to spread both legs against your hands. To test the hip adductors, place your hands between the patient's knees and ask the patient to bring the knees together. Note the strength. Continue by testing muscle strength at the knee by supporting the patient's knee in flexion and asking the patient to straighten the leg against your hand. The quadriceps is the strongest muscle in the body, so expect a forceful response. To assess knee flexion by the hamstrings, shift your hand position, but leave the patient's leg flexed at the knee. Tell the patient to keep the foot down as you try to straighten the leg. Finally, test dorsiflexion at the ankle by asking the patient to pull up against your hand, and plantar flexion by asking the patient to push down against your hand. Coordination of muscle movement requires that 4 areas of the nervous system function in an integrated way. The motor system for muscle strength, the cerebellar system for rhythmic movement and steady posture, the vestibular system for balance and for coordinating eye, head, and body movements, the sensory system for position sense. To assess coordination, observe the patient's performance in rapid alternating movements, point-to-point movements, and standing in specified ways. For rapid alternating movements, show the patient how to strike one hand on the thigh, raise the hand, turn it over, and then strike the back of the hand down on the same place. Urge the patient to repeat these movements as rapidly as possible. Now ask the patient to tap the distal joint of the ventral thumb with the tips of the fingers in sequence. Observe the speed, rhythm, and smoothness of the movements. Ask the patient to repeat these movements on the other hand. For the legs, ask the patient to tap your hand as quickly as possible with the ball of each foot in turn. Note any slowness or awkwardness. The feet normally perform less well than the hands. Next, assess point-to-point movements. Ask the patient to touch your index finger and then the nose alternately several times. Move your finger continuously so that the patient has to change directions, and observe the smoothness and accuracy of the movements and watch for any tremor. Then, with your finger held steady in one place, ask the patient to touch it, then raise the arm overhead, and then lower it to touch your finger again. After several repeats, ask the patient to close both eyes and try several more times. Normally, a person can touch the examiner's finger successfully with eyes open or closed. To test the heel-to-shin movement of the legs, ask the patient to place one heel on the opposite knee and then slide it down the shin to the big toe. The patient should be able to do this smoothly and accurately. Repeat with the patient's eyes closed to test for position sense. Continue the examination by observing the patient's gait, which provides information about coordination, position sense, and muscle strength. As the patient walks across the room, observe posture, balance, arm swing, and leg movements. Normally, balance is easy. The arms swing at the sides, and turns are accomplished smoothly. Next, ask the patient to walk heel to toe in a straight line. This kind of gait, also called tandem walking, demonstrates cerebellar function and position sense. Then have the patient walk on the toes to test the strength of plantar flexion, and on the heels to test dorsiflexion at the ankles. These actions also test balance. Next, ask the patient to hop in place, first on one leg and then the other. This ability indicates an intact motor system in the legs, normal cerebellar function, and good position sense. Finally, ask the patient to do a shallow knee bend, first on one leg and then on the other. Support the patient if you think there is danger of falling. The Romberg test primarily tests position sense. Ask the patient to stand with feet together and eyes open. Then, have the patient do the same thing for 30 to 60 seconds with eyes closed. Note the patient's ability to maintain an upright position with only minimal swaying. Now check for pronator drift by asking the patient to hold both arms forward and parallel with palms up and eyes closed for about 20 to 30 seconds. Normally, patients can hold their arm positions well. Finally, ask the patient to keep both arms up and eyes closed while you tap the arms briskly downward. Normally, the patient's arms return smoothly to the horizontal position. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. After practice and further review of this video, make sure you have mastered the important learning objectives for examining the patient's cranial nerves and motor system. Learning objectives for mastering the examination of the head, eyes, and ears are: to identify and examine key structures basic to the head, eyes, and ears, to sharpen skills for assessing and describing the patient's general appearance, including facial expression, contours, and asymmetry. To be familiar with the techniques of examination of the scalp and hair, including abnormalities. To accurately assess visual acuity, extraocular movements, pupillary reaction, auditory acuity, and to properly perform a fundoscopic exam. With the patient's health history in mind, you are now ready for the examination. Before beginning, let's review the important regions and structures of the head. Regions of the head take their names from the underlying bones of the skull. The frontal area overlies the frontal bone, the temporal area the temporal bone, the parietal area the parietal bone, the occipital area overlies the occipital bone, and the superficial temporal artery passes upward just in front of the ear where it is readily palpable. Two pairs of salivary glands lie near the mandible. The parotid glands lie superficial to and behind the mandible and become both visible and palpable when enlarged. The submandibular glands are located beneath the tongue, located deep to the mandible. The openings of the parotid and submandibular ducts are visible within the oral cavity. Common or concerning symptoms relating to the head, eyes, and ears include headache, one of the most common symptoms in clinical practice. Change in vision resulting in hyperopia, presbyopia, myopia, or scotomatas, double vision or diplopia, hearing loss, earache or tinnitus, and vertigo. By eliciting the patient's concerns before the examination, you prepare for an examination that is focused, efficient, and productive. After comprehensive hand hygiene, you are ready for the physical examination. Because abnormalities covered by the hair are easily missed, ask the patient if they have noticed anything wrong with the scalp or hair. If the patient is wearing a hairpiece or wig, ask the patient to remove it. Inspect the hair, noting its quantity, texture, distribution, and pattern of loss, if any. You may see loose flakes of dandruff. Part the hair in several areas to inspect the scalp. Look for scaliness, lumps, nevi, or other lesions. Observe the general size and contour of the skull. Note any deformities, depressions, lumps, or tenderness. Learn to recognize the irregularities in a normal skull, such as those near the suture lines between the parietal and occipital bones. When examining the patient's face, observe it at rest and during conversation, noting facial expressions and contours, and observing for asymmetry, involuntary movements, edema, and masses. Assess the color and condition of the skin on the face, noting its color, pigmentation, texture, thickness, hair distribution, and any lesions. Before examining the patient's eyes, let's review their anatomy. Note that the upper eyelid covers a portion of the iris, but does not normally overlay the pupil. The opening between the eyelids is called the palpebral fissure. The white sclera may look somewhat buff-colored at its periphery. Do not mistake this color for jaundice, which is a deeper yellow. The conjunctiva is a clear mucous membrane with two easily visible components. The bulbar conjunctiva covers most of the anterior eyeball. It adheres loosely to the underlying tissue and meets the cornea at the limbus. The palpebral conjunctiva lines the upper and lower eyelids. The two parts of the conjunctiva merge in a folded recess that permits movement of the eyeball. Within the eyelids lie firm strips of connective tissue called the tarsal plates. Each plate contains a parallel row of meibomian glands, which open on the lid margin. The levator palpebrae is the muscle that raises the upper eyelid. A film of tear fluid protects the conjunctiva and cornea from drying and infection. This fluid comes from three sources: the lacrimal gland, the conjunctival glands, and the meibomian glands. Tear fluid from the lacrimal gland above the eye drains medially through the lacrimal puncta and passes into the lacrimal sac and onto the nose through the nasolacrimal duct. You can easily find the punctum atop the small elevation of the lower lid medially. The lacrimal sac rests inside the bony orbit and is not visible. The cornea is the transparent anterior portion of the outer covering of the eye. The muscles of the iris control the size of the pupil. Muscles of the ciliary body control the thickness of the lens, allowing the eye to focus on near or distant objects. The ciliary body also produces a clear liquid called aqueous humor, which helps control the pressure inside the eye and drains out through the canal of Schlemm. The posterior part of the eye that is seen through the ophthalmoscope is called the fundus. The optic nerve enters the eyeball posteriorly. You'll find it with an ophthalmoscope at the optic disc, where the retinal arteries and veins converge. Lateral and slightly inferior to the disc is a darkened circular area called the fovea. This surrounds a small depression in the retinal surface that marks the point of central vision. The macula surrounds the fovea but has no discernible margins. Note the absence of retinal vessels in much of this area. The retina is the light-sensitive membrane that covers the fundus. A transparent mass of gelatinous material called the vitreous body fills the eyeball and is not usually visible through the ophthalmoscope. This helps maintain the shape of the eye. To see an image, light reflected from the image must pass through the pupil and be focused on sensory neurons in the retina. The image, represented here by the letter A, is projected on the retina upside down and reversed, left to right. Nerve impulses, stimulated by light, are conducted through the retina, optic nerve, and optic tract into the brain. Begin the eye examination by assessing the patient's visual acuity. Have the patient stand 20 feet from a Snellen eye chart. Patients who use contact lenses or glasses should wear them. However, patients should remove reading glasses, which can blur distance vision.
What I'd like you to do is hold this card in front of your left eye,
Okay.
and then I want you to look at the chart and read the smallest line possible.
Okay. D-E-F-P-O-T.
Visual acuity is printed at the side of the line of the eye chart and is expressed as two numbers, for example, 20/20. The first number indicates the distance of the patient from the chart, and the second number indicates the distance at which a normal eye can read the line of letters. Repeat the test on the other eye. For screening purposes, visual fields are tested by confrontation, which is a valuable technique for early detection of lesions in the anterior and posterior visual pathway. 2 tests are recommended. For the static finger wiggle test, face the patient directly and imagine a glass bowl encircling her head with the base of the bowl facing you.
Look directly into my eyes with both of your eyes.
Okay.
Ask the patient to look with both eyes into your eyes. Then, place your hands about 2 feet apart, lateral to the patient's ears. Slowly move your wiggling fingers of both
see that
hands
one at the top.
along the imaginary surface of the bowl toward the central vision line. Ask the patient to tell you as soon as she sees the finger movement.
Yeah, I see it down there.
Map out the maximum lateral extent of the left and right monocular visual fields. If you think you have found a visual defect, try to establish its boundaries, testing one eye at a time. For instance, if you suspect a temporal defect in the left visual field, ask the patient to cover the right eye and with the left eye, look into your eye opposite. Then, slowly move your wiggling fingers from the defective area of the field toward the better vision, noting where the patient first responds. Repeat this at several levels until you can define the border of the defect. Then test the other eye for an accompanying defect.
There. I see them there.
Okay.
Next, for the kinetic red target test, Face the patient and move a 5 millimeter red-topped pin inward from beyond the boundary of each quadrant along a line bisecting the horizontal and vertical meridians. Ask the patient when the pin first appears to be red. Visually inspect the patient's eyes for position and alignment.
Okay, I see it.
Also, examine the eyebrows and closely inspect the eyelids for the width of the palpebral fissures, edema, and color of the lids, any lesions, and the condition and direction of the eyelashes. Note the adequacy of eyelid closure, especially when the eyes are unusually prominent, when there is facial paralysis, or when the patient is unconscious. Inspect the area over the lacrimal gland and lacrimal sac for swelling, and look for excessive tearing or dryness. To inspect the sclera and the conjunctiva, ask the patient to look up as you depress the lower lids with your thumbs. Look for any nodules or swelling and inspect for color. Note the vascular pattern against the white scleral background. Ask the patient to look at each side and down. This will give you a good view of the sclera and bulbar conjunctiva. If you need to view the palpebral conjunctiva of the upper lid, the eyelid must be everted. With oblique lighting, inspect each cornea and lens for opacities. To do this, shine a pen light from the side toward the eye. At the same time, inspect each iris. Normally, iris markings are clearly defined. With your light shining from the temporal side, look for a crescentic shadow on the medial side of the iris, which suggests glaucoma. Inspect the size, shape, and symmetry of the pupils. You can use a gauge with circles of varying sizes to measure pupillary size. Next, test the pupillary reactions to light. First, darken the room. Then ask the patient to look into the distance. Shine a bright light obliquely into each pupil in turn. The oblique lighting and the distant gaze both help to prevent a near reaction. Look for the direct reaction, consisting of pupillary constriction in the eye being illuminated directly. Then, quickly swing the light to the other eye, looking for the consensual reaction, which is pupillary constriction in the opposite eye. If the reaction to light is questionable, test the near reaction in normal light. Testing one eye at a time, hold a pencil or your finger about 10 centimeters from the patient's eye. Ask the patient to look alternately at it and into the distance directly behind it. Watch for pupillary constriction with near effort. Next, assess ocular alignment arising from the extraocular muscles. From about 2 feet directly in front of the patient, shine a light onto the patient's eyes and ask the patient to look at it. Inspect the reflections in the corneas. They should be visible slightly nasal to the center of the pupils. Next, assess the extraocular movements, looking for the normal conjugate movements of the eyes in each direction or any deviation from normal, nystagmus, a fine rhythmic oscillation of the eyes, and lid lag as the eyes move up and down. Ask the patient to follow your finger or a pencil as you sweep through the 6 cardinal directions of gaze. Making a wide H in the air, lead the patient's gaze to the patient's extreme right, to the right and upward, down on the right, then without pausing, up to the extreme left, then upward. To detect horizontal, vertical, or rotatory nystagmus, look for a jerking movement of the eyes as the patient looks to the far left, then the far right, then up and down. If you suspect lid lag or hyperthyroidism, ask the patient to follow your finger again as you move it slowly from up to down in the midline and look for a white rim of sclera above the iris. Normally, the lid should overlap the iris slightly throughout this movement. Test for convergence of the eyes by asking the patient to look at your finger as you move it toward the bridge of the nose. The eyes can usually follow your finger to within 5 to 8 centimeters of contact. Next, After darkening the room, conduct your ophthalmoscopic examination. Switch on the ophthalmoscope light and adjust it to the large round beam of white light. Note that some examiners prefer the smaller beam of light to avoid hippus, or spasm of the ciliary muscles. Also make sure the light is set to the appropriate brightness, often about 80% of full brightness, to minimize pupillary constriction. Initially, set the ophthalmoscope to the 0 diopter. Ask the patient to look over your shoulder at a specific spot on the wall. Remember to use your right eye and right hand as you examine the patient's right eye. From 15 inches away and 20 degrees lateral to the patient's line of vision, shine the light beam on the pupil. Make sure you can see clearly through the aperture. You may wish to place the thumb of your other hand across the patient's eyebrow to help keep you steady. Locate the red reflex, which should appear as an orange glow in the pupil. Note any opacities that interrupt the red reflex. While holding the red reflex in view, move in with the ophthalmoscope on the 15-degree angle toward the pupil until the ophthalmoscope is close to the eye, almost touching your thumb. Locate the yellowish-orange structure that is the optic disc. If you do not see it at first, follow the retinal vessel centrally until you do. Now, using your index finger, bring the optic disc into sharp focus by adjusting the lens of the ophthalmoscope. Note the color of the optic disc, the size of the central physiologic cup, and the clarity of the disc margin. The cup-to-disc ratio, usually 1:3, can be elevated in glaucoma. Also note the comparative symmetry of the eyes and fundi. Normally, the optic disc is yellowish-orange to creamy pink and round or oval with well-demarcated margins. Look for papilledema, which is a swelling of the optic disc and anterior bulging of the physiologic cup. Papilledema often signals elevated intracranial pressure seen in mass lesions, meningitis, or subarachnoid hemorrhage. Moving your head and instrument as a unit, inspect the retina, including the arteries and veins as they extend from the disc to the periphery. Note the relative size and color of the narrower, lighter arteries and the larger, darker veins. Examine the surrounding retina for lesions, noting their size, shape, color, and distribution. Finally, examine the fovea and surrounding macula by directing your light beam laterally or asking the patient to look directly into the light. The tiny bright reflection at the center of the fovea may help orient you. To focus on more anterior structures, such as opacities in the vitreous body or the lens, change the diopter on the ophthalmoscope to more positive numbers, such as +10 or +12. Repeat the ophthalmoscopic examination on the patient's left eye using your left hand and left eye. Before examining the patient's ears, let's review their anatomy. The ear is composed of 3 components: the external ear, the middle ear, and the inner ear. The external ear includes the auricle and the ear canal. The auricle consists chiefly of cartilage covered by skin. Its prominent curved outer ridge is the helix. Parallel and anterior to the helix is another curved prominence called the antihelix. Inferiorly is the fleshy projection of the earlobe or lobule. The ear canal opens behind the tragus and curves inward and is about 24 millimeters long. The inner portion of the canal is surrounded by bone and lined by thin hairless skin. Pressure here causes pain, a point to remember when you examine the ear. At the end of the ear canal lies the tympanic membrane, or eardrum. Behind and below the ear is the mastoid portion of the temporal bone. The lowest portion of this bone, the mastoid process, is palpable behind the lobule. The external ear captures sound waves for transmission into the middle and inner ear. The middle ear is an air-filled cavity that transmits sound by way of the eardrum. and 3 tiny bones or ossicles, the malleus, the incus, and the stapes. The inner ear contains the cochlea, the semicircular canals, and the distal end of the cochlear nerve. Much of the middle ear and all of the inner ear are inaccessible to direct examination. These can be assessed by testing auditory function. Air conduction describes the normal first phase in the hearing pathway. An alternate pathway, known as bone conduction, bypasses the external and middle ear and is used for testing purposes. Begin the examination of the ear by inspecting the auricle and surrounding tissues for deformities, lumps, or skin lesions. If ear pain, discharge, or inflammation is present, do the tug test to test for otitis externa or external otitis. Move the auricle up and down, press the tragus, and press firmly on the mastoid bone behind the ear. Tenderness here suggests mastoiditis. Next, examine the ear canal and eardrum using an otoscope. To do this, select the largest speculum the patient's ear canal will accommodate. Position the patient's head so that you can see through the otoscope comfortably. To straighten the ear canal, grasp the auricle firmly but gently, and in an adult, pull it upward, back, and slightly away from the head. Insert the speculum gently into the ear canal, directing it somewhat downward and forward, bracing your hand against the patient's face. Note any cerumen or earwax that may impair your view. Also, observe for any discharge, foreign bodies, redness of the skin, or swelling. Maneuver the speculum until you can see as much of the eardrum as possible, including the pars flaccida, if possible, and the margins of the pars tensa. Note the color and contour of the eardrum with its distinct cone of light. Normally, the drum is pearly gray. Also, note the position of the handle of the malleus and inspect the short process of the malleus. The handle of the malleus, with the umbo at its tip, crosses the eardrum obliquely from the cone of light upward toward the short process. Be sure to examine the other ear in the same manner. To assess hearing, ask the patient,
Do you feel you have a hearing loss or any difficulty hearing?
if the patient reports hearing loss, proceed to the whispered voice test. To assess hearing, test one ear at a time. Stand 2 feet behind the seated patient. Occlude the non-test ear of the patient with your finger and gently rub the tragus in a circular motion to prevent transfer of sound to that ear.
And now tell me what I'm saying.
Exhale fully to ensure a quiet voice, and test the open ear by softly whispering a combination of 3 numbers and letters. Gradually increase your volume until the patient can identify your words. If the patient responds incorrectly, test a second time with a different number-letter combination. In a normal response, the patient will repeat at least 3 out of the possible 6 numbers and letters correctly. Repeat on the other side. For patients failing the whispered voice test, a tuning fork test helps determine if the hearing loss is conductive or neurosensory in origin. In a quiet room, select a tuning fork of 256 or 512 Hz, as these frequencies fall in the range of conversational speech. Set the fork into light vibration by tapping it on your hand. Test for lateralization by performing the Weber test. Place the base of a vibrating tuning fork firmly on top of the patient's head or on the mid-forehead. Then ask,
Is the sound louder in one ear or the same in both ears?
It's the same in both ears.
Normally, the sound is heard in the midline or equally on both sides. Next, compare air and bone conduction by performing a René test. Place a lightly vibrating tuning fork on the mastoid bone behind the ear and level with the canal. When the patient indicates that the sound is no longer heard, quickly place the vibrating fork near the ear canal and ask if the sound can be heard. The U of the fork should face forward, maximizing the sound for the patient. Normally, the sound can be heard longer through the air than through bone. Be sure to test the opposite ear. Remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
The skull is normocephalic and atraumatic. Hair has average texture. Eyes with visual acuity, 20/20 bilaterally. Sclera white, conjunctiva pink.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the patient's head, eyes, and ears.
Dr. Bickley, and it's very nice to meet you, Jason.
Nice to meet you.
And
Your learning objectives for mastering the examination of the musculoskeletal system are to understand the link between anatomy and functional movement for each of the major joints, and to perform the techniques and maneuvers needed for assessing the range of motion, function, and soft tissues for each of the major joints. It is also important to recognize the changes of inflammatory and degenerative joint disease and trauma. Musculoskeletal disorders are the leading cause of medical office visits in the United States. Common or concerning symptoms relating to the musculoskeletal system include neck pain, low back pain, monoarticular or polyarticular joint pain, inflammatory or infectious joint pain with systemic features such as fever, chills, rash, anorexia, weight loss, and weakness, and joint pain with symptoms from other organ systems. Some tips for assessing joint pain are: always ask the patient to point to the pain, since not all patients explain pain well. Clarify when the pain started, and especially the mechanism of injury or exactly how the pain began. For example, the detail relating to trauma or from a particular exercise or movement. Identify key features of the pain. Is it localized or diffuse, acute or chronic, inflammatory or non-inflammatory? With the patient's health history in mind, and by eliciting the patient's concerns before the examination, you prepare for an examination that is focused, efficient, and productive. As you examine each joint, be sure to look for joint symmetry, alignment, bony deformities, and swelling. Assess the surrounding tissues, noting skin changes, subcutaneous nodules, and muscle atrophy. Test range of motion and perform maneuvers to demonstrate limitations. Note any swelling, warmth, tenderness, or redness. Before examining the head and neck, let's review their anatomy. In the head, the temporomandibular joint, or TMJ, arises from the articulation between the mandible and the skull. A fibrocartilaginous disc cushions the action of the condyle of the mandible against the synovial membrane and capsule of the articulating surfaces of the temporal bone. After comprehensive hand hygiene, you are ready for the physical examination. Begin the examination by assessing the temporomandibular joint. Place the tips of your fingers in front of the tragus of each ear. Then ask the patient to open and close his mouth. Your fingertips should drop into the joint spaces as the mouth opens. Check for a smooth range of motion. Feel for swelling and note any tenderness or crepitus. Palpate the muscles of mastication, the temporal muscles, the pterygoid muscles, and the masseters. Ask the patient to demonstrate protrusion and retraction by jutting the mandible forward and lateral and side-to-side motion. When you assess the shoulders, identify the following important landmarks and articulations. The bony structures of the shoulder include the humerus, the clavicle, and the scapula. 3 different joints articulate the shoulder: the glenohumeral joint, the sternoclavicular joint, and the acromioclavicular joint. 3 groups of muscles attach at the shoulder: The scapulohumeral group includes the important sits muscles, or the rotator cuff, supraspinatus, infraspinatus, and teres minor, and subscapularis muscles. The axioscapular group includes the trapezius, rhomboids, serratus anterior, and levator scapulae muscles. The axiohumeral group includes the pectoralis major and minor and the latissimus dorsi muscles. Begin by inspecting the shoulder and shoulder girdle anteriorly. Inspect the scapulae and related muscles posteriorly. During both inspections, note any swelling, deformity, muscle atrophy, or fine tremors of the muscles. Palpate for tenderness at the sternoclavicular joint, tracing the clavicle laterally with your fingers. From behind, follow the bony spine of the scapula laterally and upward until it becomes the acromion, the summit of the shoulder. From there, palpate the acromioclavicular joint, and from there down to the coracoid process of the scapula. Palpate the greater tubercle and the biceps tendon in the intertubercular groove, checking for tenderness. Also, lift the humerus posteriorly so you can palpate over the subacromial bursa and subdeltoid bursa and the underlying palpable sits muscles, which include the supraspinatus, infraspinatus, teres minor, and subscapularis. To evaluate the range of motion of the shoulders, ask the patient to perform the 6 motions of the shoulder girdle. These include flexion, where the patient raises his arm in front and overhead; extension, where he moves his arms behind; abduction, raising his arms out to the side and overhead; adduction, crossing an arm in front of his body; internal rotation, placing a hand behind his back to touch his shoulder blade; and external rotation, rotating an arm toward the ceiling from shoulder level. If you suspect a problem, cup your hand over the patient's shoulders and feel for crepitus as the patient repeats the movements. Examination of the shoulders often calls for the patient to perform maneuvers to test specific motions and structures. This maneuver assesses the acromioclavicular joint and is sometimes called the crossover test. The aptly scratched test tests overall shoulder rotation. Assess the rotator cuff, the most common source of shoulder pain. When positive, Neer's impingement sign suggests a rotator cuff sprain. Hawkins' impingement sign also indicates rotator cuff sprain or tear. Now for direct testing of the sits muscles. To assess the supraspinatus, do the empty can test.
And don't let me push. Any problems? Any pain? Excellent.
Test for function and pain in the infraspinatus with this maneuver.
Keep your thumbs up and press out against my hands. Okay? Any pain?
Now test for forearm supination.
Now I'd like you to turn them around like you're holding a bowl of soup. Go ahead. And I'm pressing. Any pain?
Test the drop arm sign by asking the patient to fully abduct the arm to shoulder level, that is to 90 degrees, and then to lower it slowly. When positive, these tests suggest rotator cuff sprain, partial tear, or full tear, depending on the severity of loss of function. Before examining the elbows, let's review their basic anatomy. Assessment of the elbow joint includes examination of the ulna, its olecranon process, the overlying olecranon bursa, and the medial epicondyle of the humerus. The bones of the elbow have 3 articulations: the humero-ulnar joint, the radiohumeral joint, and the radio-ulnar joint. Notice also in this anterior view the lateral epicondyle of the humerus. Support the patient's forearm so that the elbow is flexed to about 70 degrees. Inspect and palpate the elbow, including the medial and lateral epicondyles, the olecranon processes in the groove between the epicondyles, and the extensor surface of the ulna. Note any nodules or swelling that suggest olecranon bursitis or arthritis. Normally, you cannot palpate either the synovium or the olecranon bursa. Note any tenderness or effusion, as well as any displacement of the olecranon or the olecranon process, particularly if there is a history of trauma. The sensitive ulnar nerve can be felt posteriorly between the olecranon process and the medial epicondyle. Next, assess the range of motion of the patient's elbows. To test flexion and extension, have the patient bend and then straighten his elbows. To check supination and pronation, ask the patient to flex his elbows at 90 degrees and turn his palms up and then down. Before examining the patient's wrists and hands, consider these important structures. Bones of the wrist and hand include the distal radius and ulna, the carpal bones, the metacarpals, and the phalanges. The joints of the hand include the metacarpophalangeal, MCPs, proximal interphalangeal, PIPs, and distal interphalangeal, DIPs. Related joints include the distal radioulnar joint, radiocarpal, and intercarpal and phalangeal joints. Be familiar with the structures in the carpal tunnel. This channel contains the sheath and flexor tendons of the forearm muscles and the median nerve. Holding the tendons and tendon sheath in place is the transverse flexor retinaculum. Observe the position of the hands in motion to see if movements are smooth and natural. When fingers are relaxed, they should be slightly flexed. Inspect the patient's wrists and hands, noting any swelling over the joints, as well as any deformities or angulation. Observe the contours of the palm, namely the thenar and hypothenar eminences. Note any thickening of the tendons or fingers. Palpate the distal radius and ulna on the lateral and medial surfaces of the wrist. Palpate the radial styloid bone and the anatomical snuff box, a hollowed depression just distal to the radial styloid process. Pain when palpating the snuff box suggests a scaphoid fracture. Palpate over the 8 carpal bones lying distal to the wrist joint, and then each metacarpophalangeal joint. Compress the MCP joints by squeezing the hand from each side between the thumb and fingers. Note any tenderness, swelling, or bogginess. Now palpate the medial and lateral aspects of each of the proximal interphalangeal joints between the thumb and index finger, noting any swelling, bogginess, bony enlargement, or tenderness. Bony nodules at the PIP joints, or Bouchard's nodes, are common in osteoarthritis. They are benign. Using the same techniques, examine the DIP joints. Benign bony nodules at the DIP joints, or Heberden's nodes, are also common in osteoarthritis. Repeat on the other hand. To check range of motion of the wrists and hands, begin with flexion and extension.
Okay. So turn your hands palms up, and then just bring the fingers up toward your face. Good. Palms flat.
Okay.
And down toward your toes.
Continue to assess range of wrist movement with adduction and abduction.
With your palm down, bring your wrist into flat position and turn it away and towards you. Very good.
If there are complaints of wrist pain suggesting carpal tunnel syndrome, test sensation by assessing the median nerve in the pulp of the index finger, the ulnar nerve in the pulp of the 5th finger, and the radial nerve in the dorsal web space of the thumb and index finger. Other tests include hand grip strength.
We're going to check the strength of your fingers, your hand grip. Squeeze as hard as you can. Okay, very good.
Loss of grip strength is seen in de Quervain's tenosynovitis, or inflammation of the thumb extensor tendon, arthritis, and cervical radiculopathy.
Let's check out your wrist pain. Grab your thumb in your palm and squeeze hard. Turn in this way a little bit.
Make note of any wrist pain with extension of the wrist toward the midline in ulnar deviation, or a positive Finkelstein's test for de Quervain's tenosynovitis.
Any problems?
No.
Let's check your thumb, your range of motion.
Perform tests for carpal tunnel syndrome, first using thumb abduction.
So I want you to just lift your thumb out like that and go ahead. Any problems there?
No.
Now Tinel's sign for median nerve compression.
Any pain in your second, third, or fourth fingers?
No.
Or tingling?
No.
What I'd like you to do is put the backs of your two hands together. Just
And
raise-
Phelan's sign for median nerve compression.
If there's a problem, you should again feel tingling in your second, third, and fourth fingers. Any problem?
No.
The vertebral column, or spine, is the central supporting structure of the trunk and back. The vertebral column contains 24 vertebrae stacked on the sacrum and coccyx. Each vertebra contains a spinous process which projects posteriorly in the midline. Transverse processes are at the junction of the pedicle and the lamina. The articular processes, 2 on each side of the vertebra, are often called articular facets. Note the intervertebral foramen formed by the inferior and superior articulating process of adjacent vertebrae. Between the vertebral bodies are the intervertebral discs, which cushion movement and allow the vertebral column to curve, flex, and bend. Also note the vertebral foramen, which encloses the spinal cord. The trapezius and the latissimus dorsi form the large outer layer of muscles attaching to each side of the spine. They overlie 2 deeper muscle layers, a layer attaching to the head, neck, and spinous processes, and a layer of smaller intrinsic muscles between the vertebrae. Begin the examination of the spine by observing the patient's posture, including the position of the neck and trunk. Assess the patient for erect position of the head, neck, and back. Drape or gown the patient to expose the entire back. If possible, the patient should be in a natural standing position, with feet together and arms at the sides. From behind the patient, identify the spinous processes, paravertebral muscles, iliac crests, and posterior superior iliac spines, usually marked by skin dimples. Next, palpate the spinous processes of each vertebra for tenderness. In the neck, palpate the facet joints that lie between the cervical vertebrae. Palpate the sacroiliac joint, often identified by the dimple. And inspect and palpate the paravertebral muscles for tenderness and spasm. With the patient lying on one side with one leg extended and the upper leg with the hip flexed, palpate the sciatic nerve, the largest nerve in the body. It lies midway between the greater trochanter and the ischial tuberosity. Next, inspect the neck, including the sternomastoid muscles, for symmetry, deformities, swelling, or abnormal posture. Then palpate the spinous processes of the cervical spine, as well as the trapezius muscles and the muscles between the scapulae. Identify any areas of tenderness. Now test range of motion of the cervical spine. To test flexion, have the patient touch his chin to his chest. To assess for extension, ask the patient to tilt his head back. Note any limitations in range of motion. To check rotation, have him turn his chin to his right shoulder, then to his left shoulder. For lateral bending, ask him to bend his head toward his right shoulder and toward his left shoulder. Next, for range of motion of the lower spine, begin with flexion. Curvature of the spine or unequal heights of the shoulders suggest scoliosis. Then move on to extension. The next maneuver is rotation. To assess lateral bending, have the patient bend to his right and then to his left. Pain or tenderness with these maneuvers warrants additional neurologic testing. To prepare for examination of the hips, let's review the pertinent anatomy. The hip joint lies deep to the inguinal ligament. Because of its overlying muscles and location deep in the pelvis, the hip joint is not readily palpable. On the anterior aspect of the hip, you can identify the iliac crest, the iliac tubercle, the anterior superior iliac spine, the greater trochanter, and the pubic tubercle. On the posterior aspect of the hip, note the posterior superior iliac spine, the greater trochanter, the ischial tuberosity, and the sacroiliac joint. 4 powerful muscle groups move the hips. The flexor group, which lies anteriorly and flexes the thigh, primarily the iliopsoas, the extensor group, primarily the gluteus maximus, the adductor group, which swings the thigh toward the body, and the abductor group, which moves the thigh away from the body. Inspection of the hip begins with careful observation of the 2 phases of the patient's gait. Stance, when the foot is on the ground and bears weight, and swing, when the foot moves forward and does not bear weight. Normal gait has a smooth, continuous rhythm. Most hip problems appear during the weight-bearing stance phase. Palpate the bony landmarks, including the iliac crest at the upper margin of the pelvis at the level of L4. From there, you can follow the downward anterior curve to locate the iliac tubercle, marking the widest point of the crest. Tracking downward, you'll find the anterior superior iliac spine. Place your thumbs there and move your fingers downward to find the greater trochanter of the femur. Move your thumbs medially and obliquely to the pubic tubercle. On the posterior aspect of the hip, palpate the posterior superior iliac spine directly underneath the visible dimples just above the buttocks. Next, locate the greater trochanter at the level of the gluteal fold and place your thumb medially on the ischial tuberosity. The sacroiliac joint is not always palpable, but may be tender. Note that an imaginary line between the posterior superior iliac spines crosses the sacroiliac joint at S2. Then, palpate along the inguinal ligament. Here, the femoral nerve, artery, and vein bisect the overlying inguinal ligament, while the lymph nodes lie medially. The mnemonic navel may help you remember the lateral to medial sequence of nerve, artery, vein, empty space, lymph node. If the hip is painful, with the patient lying on the side and the upper hip flexed, palpate the trochanteric bursa, lying over the greater trochanter, and the ischio-gluteal bursa over the ischial tuberosity, which is not palpable unless inflamed. Now assess the mobility of the patient's hips. First, check flexion. With the patient supine, place your hand under the patient's lumbar spine. Ask the patient to bend a knee up to the chest and firmly against the abdomen. Note when the back touches your hand, indicating normal flattening of the lumbar lordosis. Further flexion must arise from the hip joint itself. Observe the degree of flexion at the hip and knee. Normally, the anterior portion of the thigh can almost touch the chest wall. Note whether the opposite thigh remains fully extended, resting on the table. If the opposite thigh flexes, there may be a flexion deformity of the hip. Next, check extension. Have the patient hyperextend the thigh in a posterior direction. Check abduction next. Stabilize the pelvis by pressing down on the opposite anterior superior iliac spine with one hand. With the other hand, grasp the ankle and abduct the extended leg until you feel the iliac spine move. This movement marks the limit of hip abduction. Next, check adduction. With one hand on the patient's opposite hip, hold one ankle and move the leg medially across the body and over the opposite extremity. Test internal and external rotation of the hip. When this helpful test is normal, hip arthritis is less likely. Flex the leg to 90 degrees at the knee. Then stabilize the thigh with one hand and grasp the ankle with the other. Now swing the lower leg medially for external rotation at the hip and laterally for internal rotation. Repeat each of these maneuvers on the opposite side. To accurately assess the knee, the largest joint in the body, you must thoroughly understand the important features of the anatomy of the knee joint. On the medial surface, note the adductor tubercle, the medial epicondyle of the femur, and the medial condyle of the tibia. On the lateral surface, note the lateral epicondyle of the femur, the lateral condyle of the tibia, and the head of the fibula. 7 key structures determine knee function. 4 ligaments help stabilize the knee: the medial collateral ligament, MCL, the lateral collateral ligament, LCL, the anterior cruciate ligament, ACL, and the posterior cruciate ligament, PCL. The medial and lateral menisci cushion knee compression. Note also the patellar tendon, necessary for lower leg extension. On the anterior surface, note the patella, which rests on the surface of the femur midway between the epicondyles, embedded in the tendon of the quadriceps muscle. This tendon continues as the patellar tendon, which inserts distally on the tibial tuberosity. On the upper surface of the tibia lie the medial meniscus and the lateral meniscus. The menisci cushion some of the stress on this weight-bearing joint. The powerful muscle groups that support the knee include the quadriceps femoris, which extends the knee, and the hamstring muscles which flex the knee. With the patient supine on the examining table and with his knees in flexion, inspect the knees, noting their alignment and any deformities. Note loss of the normal hollows around the patella or atrophy of the quadriceps muscles. Then, straighten the patient's leg and palpate the suprapatellar pouch on each side of the quadriceps, noting any swelling. Palpate the tibiofemoral joint, the edge of the tibial plateau, and the margins of the joint. Note any irregular bony ridges. Palpate the medial meniscus. Then palpate the lateral meniscus. Tenderness suggests a partial tear. With the knee flexed 90 degrees, assess the medial joint compartments for any tenderness. Palpate the medial femoral condyle, the adductor tubercle, and the medial tibial plateau. Also palpate and identify the medial collateral ligament. Assess the lateral joint compartment and palpate the lateral femoral condyle, the lateral tibial plateau, and the lateral collateral ligament. Assess the range of motion of each knee beginning with flexion and extension. Be sure to provide support as needed. Check internal and external rotation of the knee. Instruct the sitting patient to swing the lower leg toward the midline and away from the midline. You have already palpated the menisci for tenderness, 2 of the 7 major structures of the knee joint. To test the medial collateral ligament, or MCL, perform the abduction or valgus stress test, where you move the thigh about 30 degrees laterally to the side of the examination table, push medially against the knee, and pull laterally at the ankle to open the knee joint on the medial side. Injuries from trauma or sports to both the medial meniscus and the MCL are common. To test the lateral collateral ligament, or LCL, perform the adduction or varus stress test, where you push laterally against the knee and pull medially at the ankle to open the knee joint on the lateral side. To test the anterior cruciate ligament, or ACL, check for the anterior drawer sign, where you draw the tibia forward and observe if it slides forward, like a drawer, from under the femur. To test the posterior cruciate ligament, or PCL, check for the posterior drawer sign, where you push the tibia posteriorly and observe the degree of backward movement on the femur. Now ask the patient to extend the leg to check the integrity of the patellar tendon. Before examining the patient's ankles and feet, let's review the anatomic structures that are important to your assessment. The ankle is the hinge joint formed by the tibia, the fibula, and the talus. The principal joints are the tibio-talar joint and the subtalar joint. The medial malleolus is the bony prominence at the distal end of the tibia, and the lateral malleolus at the distal end of the fibula. The heel bone is called the calcaneus. Note the strong Achilles tendon. Ligaments include the deltoid ligament fanning out from the medial malleolus, the anterior and posterior talofibular ligaments, and the calcaneofibular ligament. With the patient supine, inspect the patient's ankles and feet. Note any deformities, nodules, swelling, corns, or calluses. With your thumbs, palpate the anterior aspect of each ankle joint, noting any bogginess, swelling, or tenderness. Feel along the Achilles tendon for nodules and tenderness. Palpate the heel, especially the posterior and inferior calcaneus, for tenderness. Palpate the plantar fascia as well. Palpate over the medial and lateral malleolus, especially in cases of trauma. Compress the forefoot and the metatarsophalangeal joints for tenderness. Palpate the heads of the 5 metatarsals and the grooves between them. To assess the range of motion of the ankle, begin with the ankle or plantar flexion and ankle extension or dorsiflexion. Evaluate inversion of the ankle and eversion of the ankle. Stabilize the heel and invert and evert the forefoot. Finally, move the proximal phalanx of each toe up and down. There should be no limitation of movement or pain. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
Full range of motion in all joints. Hands with no degenerative changes of Heberden's nose in the DIPs. Proximal interphalangeal joints are normal. No pain with flexion, extension, or rotation of the hips.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the patient's musculoskeletal system.
Can you tell me about some of the medications you've been trying?
Your learning objectives for mastering the examination of the nose, mouth, and neck are to identify key anatomic structures of the nose, mouth, and neck, to master examination techniques for the nose, mouth, and pharynx and neck, including the thyroid gland and lymph nodes, and to assess common abnormalities such as pharyngitis and changes in the thyroid gland. Let's review the anatomy of the nose. Approximately the upper third of the nose is supported by bone, the lower 2/3 by cartilage. Note the bridge of the nose, the tip, and the ala nasi. Air enters the nasal cavity by way of the anterior nares, passing on either side through widened areas known as the vestibules. The nasal septum forms the medial wall of each nasal passage. Like the external nose, the nasal septum is supported by both bone and cartilage. The medial wall is covered by a mucous membrane well supplied with blood. The vestibule, unlike the rest of the nasal cavity, is lined with hair-bearing skin rather than mucosa. Air enters through the vestibules and through the narrow nasal passages to the nasopharynx. Protruding into the nasal cavity are the turbinates, curving bony structures covered by a highly vascular mucous membrane. Below each turbinate is a groove, or meatus, each named according to the turbinate above it. Draining into the inferior meatus is the nasolacrimal duct. Into the middle meatus drain most of the paranasal sinuses. Their openings are not usually visible. The paranasal sinuses are air-filled cavities located within the bones of the skull and lined with mucous membrane. Only the frontal sinus and the maxillary sinus are readily accessible to clinical examination. Common or concerning symptoms relating to the nose, mouth, and neck include nosebleed or epistaxis, sore throat, hoarseness, swollen glands, and goiter. Before you start your examination, make sure the examination equipment is within easy reach, including otoscope, tongue blades, and gloves. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. Begin by inspecting the anterior and inferior surfaces of the nose. Note asymmetry or deformity. Some asymmetry of the two sides is normal. Test for obstruction by pressing on each ala nasi in turn and asking the patient to breathe in.
Breathe in gently for me.
Then, tilt the head back, press gently on the tip of the nose, and shine a light into the vestibule to get a partial view of each nasal vestibule. To inspect the inside of the nasal passages, use an otoscope with the largest cap or speculum available. Be sure to insert the speculum carefully, avoiding contact with the sensitive nasal septum. Hold the otoscope handle to one side to avoid the patient's chin and improve your mobility. Repeat this procedure on the opposite side of the nose. Note the color and condition of the nasal mucosa that covers the nasal septum and the middle and inferior turbinates. Normally, the nasal mucosa is redder than the oral mucosa and displays no swelling, exudates, or bleeding. Note any deviation, inflammation, or perforation of the nasal septum. Look for any abnormalities, such as polyps seen in allergies or ulcerations associated with use of nasal cocaine. Discard or clean and disinfect all nasal and ear specula appropriately. Conclude your examination of the nose by palpating for sinus tenderness. Press on the frontal sinuses from under the bony brows, avoiding pressure on the eyes. Then press up on the maxillary sinuses. Before examining the mouth, let's review the anatomy. The lips are muscular folds surrounding the entrance to the mouth. When the mouth is open, the gums, or gingival mucosa, and teeth become visible. The gingiva are firmly attached to the teeth and to the maxilla or mandible in which they are seated. Note the scalloped shape of the gingival margins and the pointed interdental papillae. In lighter-skinned people, the gingiva are pale or coral pink and lightly stippled. In darker-skinned people, the gingiva may be diffusely or partly brown. A midline mucosal fold, called a labial frenulum, connects each lip with the gingiva. Adjacent to the gingiva is the alveolar mucosa, which merges with the labial mucosa of the lip. Each tooth, composed chiefly of dentin, lies rooted in a bony socket with only its enamel-covered crown exposed. A shallow gingival sulcus between the gum's thin margin and each tooth is not readily visible. Small blood vessels and nerves enter the tooth through its apex and pass into the pulp canal and pulp chamber. The dorsum of the tongue is covered with papillae, giving it a rough surface. Some of these papillae look like red dots, which contrast with the thin white coat that often covers the tongue. The undersurface of the tongue has no papillae. Note the midline lingual frenulum that connects the tongue to the floor of the mouth. At the base of the tongue, the ducts of the submandibular gland, known as Wharton's ducts, pass forward and medially. They open on papillae that lie on each side of the lingual frenulum. Each parotid duct, or Stenson's duct, empties into the mouth near the upper second molar, where a small papilla frequently marks its location. The buccal mucosa lines the cheek. Above and behind the tongue rises an arch formed by the anterior and posterior pillars, soft palate, and uvula. Between the pillars on both sides of the mouth, tonsils can be seen in their fossae, or cavities. In adults, the tonsils are often small or absent. Between the soft palate and tongue, the pharynx is visible. The hard palate forms the roof of the mouth. Before examining the mouth, ask the patient to remove any lipstick or dentures. Wearing gloves, inspect the outer surfaces of the lips for symmetry, color, and moisture. Note any lumps, ulcers, cracking, or scaling.
I'm just going to look inside your mouth. If you can open wide.
With good lighting and the help of a tongue blade, inspect the oral mucosa for color and ulcers, which can be seen in herpes simplex, white patches suggesting candida infection, and nodules. Note the color of the gums. Inspect the gum margins and the interdental papillae for swelling or ulceration. Also inspect the teeth, noting any that are missing, discolored, misshapen, or abnormally positioned. Untreated caries can lead to bacteremia and endocarditis. With your gloved thumb and index finger, check for any teeth that might be loose and lead to risk of aspiration, especially in older adults. Next, inspect the color and architecture of the hard palate.
Good. And if you can just give me a big
As the patient says ah or yawns, note the movement of the soft palate and uvula. The soft palate should rise symmetrically, and the uvula should stay in the midline. If the patient's tongue obstructs your view, use your tongue blade to depress it, but not so far that you cause gagging. Inspect the anterior and posterior pillars, tonsils if present, and pharynx. Look for redness, exudates, or ulceration. None should be present. Fever, anterior exudates, cervical lymphadenopathy, and no cough are highly suspicious of streptococcal pharyngitis.
If you can open your mouth and stick your tongue right at me. Good.
Continue by inspecting the tongue. Note its symmetry and color. Inspect its dorsal surface, which is normally roughened by papillae and sometimes covered by a thin white coating. Using a gauze square, use your right gloved hand to grasp the tip of the tongue and gently pull it to the patient's left to inspect the undersurface and sides of the tongue. Look for white or reddened areas, nodules, or ulcers. Palpate the tongue with your left gloved hand, feeling for any induration. Reverse the process for the other side. Before we examine the neck, let's look at the pertinent structures. For descriptive purposes, each side of the neck is divided into two triangles by the sternomastoid muscle. The anterior triangle is bounded above by the mandible, laterally by the sternomastoid, and medially by the midline of the neck. The posterior triangle extends from the sternomastoid to the trapezius and is bounded below by the clavicle. A portion of the omohyoid muscle crosses the lower portion of the posterior triangle. Inexperienced examiners may mistake the omohyoid muscle for a lymph node or mass. Deep to the sternomastoids run the great vessels of the neck, the carotid artery, and the external jugular vein, which passes diagonally over the surface of the sternomastoid and may be helpful when trying to identify the jugular venous pressure. Familiarity with the following midline structures is key to a successful examination. The mobile hyoid bone lies just below the mandible. The thyroid cartilage is readily identified by the notch on its superior edge. The cricoid cartilage, the tracheal rings, and the thyroid gland are also prominent structures. The thyroid isthmus lies across the trachea below the cricoid. The lymph nodes of the head and neck are classified in a variety of ways. The overlying sternomastoid muscle largely obscures the deep cervical chain, but at its two extremes, the tonsillar node and supraclavicular nodes may be palpable. The submandibular nodes lie superficial to the submandibular gland. Note that the tonsillar, submandibular, and submental nodes drain portions of the mouth and throat as well as the face. Knowledge of the lymphatic system is important to sound clinical examination. Whenever a malignant or inflammatory lesion is observed, look for enlargement of the nearby regional lymph nodes that drain it. Whenever a node is enlarged or tender, look for a nearby source of infection. To begin the examination of the neck, inspect for symmetry while standing in front of the patient and note any masses or scars, for example from a thyroidectomy or carotid endarterectomy. Look for enlargement of the parotid or submandibular glands and note any visible lymph nodes. Palpate the lymph nodes. Using the pads of your index and middle fingers, move the skin over the underlying tissues in each area. The patient should be relaxed with the neck flexed slightly forward and, if needed, turned slightly toward the side being examined. Palpate the anterior superficial and deep cervical chains, including the supraclavicular nodes located anterior and superficial to the sternomastoid. Note the node's size, shape, delimitation, mobility, consistency, and any tenderness. Small, mobile, discrete, non-tender nodes, sometimes termed shoddy, are found in normal people. Feel for the preauricular, posterior auricular, occipital, tonsillar, submandibular, submental, superficial cervical, and posterior cervical nodes. Palpate the posterior cervical chain along the anterior edge of the trapezius and along the posterior edge of the sternomastoid. Sore throat, palatal petechiae, and posterior adenopathy suggest mononucleosis. Enlarged or tender nodes call for re-examination of the regions they drain and careful assessment of lymph nodes elsewhere. Now inspect and palpate the trachea for deviation. Place your finger along one side of the trachea and note the space between it and the sternomastoid. When compared to the other side, the spaces should be symmetric. Next, start the examination of the thyroid by inspecting the patient's neck. Tip the patient's head back a bit and inspect the region below the cricoid cartilage for the gland. With tangential lighting, you should be able to see the lower shadowed border of the thyroid glands. Ask the patient to extend her neck back slightly again as she sips some water and swallows. Observe for upward movement of the thyroid gland, noting its contour and symmetry, often a butterfly shape. The thyroid gland, the thyroid cartilage, and the cricoid cartilage all rise with swallowing, then fall to their resting positions. Confirm your visual observations by palpating the thyroid gland. First, locate the isthmus, usually overlying the 2nd through 4th tracheal rings. Palpate the adjacent right and left lobes as you stand facing the patient. Look for goiter or enlargement of these lobes. Now move behind the patient and place the fingers of both hands on the patient's neck so that your index fingers are just below the cricoid cartilage. Again, ask the patient to take a sip of water and then to swallow it. Feel for the thyroid isthmus rising under your finger pads. Displace the trachea to the right with the fingers of the left hand. With the right hand fingers, palpate laterally for the right lobe of the thyroid in the space between the displaced trachea and the relaxed sternomastoid. Find the lateral margin. In a similar fashion, examine the left lobe. Note the size, shape, and consistency of the thyroid gland and identify any nodules or tenderness. If the thyroid gland is enlarged, listen over the lateral lobes with a stethoscope to detect a bruit, a sound similar to a cardiac murmur but of a non-cardiac origin seen in thyrotoxicosis. Remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
Nose, nasal mucosa is pink, septum midline, no sinus tenderness. Mouth, oral mucosa is pink, no caries, dentition is good. Posterior pharynx without exudate.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the patient's nose, mouth, and neck.
A little bit about the abdominal pain that you've been experiencing.
Your learning objectives for mastering the abdomen examination are to inspect for symmetry, scars, and striae, to auscultate bowel sounds, percuss the liver, and measure its span. You will perform light and deep palpation of the abdomen and palpate the liver edge. You will examine the spleen and assess costovertebral angle tenderness. You should be skilled at assessing for guarding and rebound tenderness, and be able to listen for and identify abdominal and inguinal bruits. Common or concerning symptoms relating to the abdomen and which are specific to gastrointestinal disorders include indigestion, nausea, vomiting, hematemesis, abdominal pain, dysphagia and odenophagia, change in bowel function, constipation or diarrhea, and jaundice. Common or concerning symptoms relating to the abdomen and which are specific to urinary and renal disorders include suprapubic pain, dysuria, urgency or frequency, hesitancy, decreased stream in males, polyuria or nocturia, urinary incontinence, hematuria, kidney or flank pain, and ureteral colic. Eliciting the patient's concerns before the examination makes your examination more efficient and more reassuring to the patient. Before beginning, let's review the anatomy of the abdomen. The abdominal wall extends from the rib cage above to the pelvis and inguinal ligaments below. The rectus abdominis muscles can be identified when the patient raises both head and shoulders from a supine position. Palpation is easier lateral to these muscles. For descriptive purposes, the abdomen is divided by imaginary lines that cross at the umbilicus. These lines form the right upper, right lower, and left lower quadrants. The abdomen may also be divided into 9 areas. The 3 midline areas are the epigastric, umbilical, and hypogastric or suprapubic areas. The abdominal cavity extends up under the rib cage to the dome of the diaphragm. Most of the liver and stomach, and usually all of the spleen, are within the abdominal cavity. The normal spleen is mostly posterior to the left mid-axillary line. The abdominal aorta, usually palpable in the upper abdomen, bifurcates into the common iliac arteries below the umbilicus. As the external iliac arteries pass under the inguinal ligaments, they become the femoral arteries. The intestines fill much of the abdomen. The sigmoid colon and portions of the transverse and descending colons may be palpable as tubular structures. Except for a pregnant or gravid uterus or a distended bladder, normal pelvic organs are not detectable through the abdominal wall. The kidneys lie posteriorly, partly protected by the posterior ribs. The right kidney is slightly lower than the left. To assess for kidney tenderness, locate the costovertebral angles. They are posterior to and below the 12th ribs lateral to the vertebrae. With the patient's health history in mind, and after good hand hygiene, you are ready to examine the abdomen. Before you examine the abdomen, make sure that the patient has emptied his bladder. Lower the table flat. Then, ask the patient to lie down and relax. Expose the supine patient's lower abdomen by raising the gown to below the nipple line and lowering the drape to the suprapubic level. Inspect the skin for scars, striae, dilated veins, rashes, or ecchymoses. Inspect the symmetry and contour of the abdomen. Is it flat, rounded, protuberant, or markedly concave or hollowed? Are there any bulges? Observe the contour of the umbilicus to look for signs of inflammation or hernias. Are peristalsis or aortic pulsations visible in the epigastrium? Warm your hands and your stethoscope. Listen for bowel sounds by placing the diaphragm of the stethoscope gently over each quadrant. Listen to the abdomen before performing percussion, because these maneuvers may alter the frequency of bowel sounds. Occasionally, you may hear the normal stomach growling. If the patient has high blood pressure or atherosclerotic disease, listen in the epigastrium over the aorta. Then listen over the iliac arteries and the femoral arteries.
Okay, everything sounds fine.
Next, lightly percuss the abdomen to assess the distribution of tympany and dullness. Tympany is a high-pitched musical sound that indicates a hollow space filled by air or gas in the stomach or intestine. Dullness suggests fluid or underlying organs like the liver and spleen.
Okay, continue to stay relaxed. Let me know if you feel any tenderness.
Now palpate the 4 quadrants of the abdomen, beginning gently and saving painful areas for last. With your fingers together, place your hand flat on the abdomen and press, using a light dipping motion. Moving smoothly, palpate all quadrants, identifying any tenderness or increased resistance to your hand. Observe the patient's face closely for indications of tenderness or discomfort.
Okay, take some slow, deep breaths for me, please, and just try to relax as much as you can.
If the abdominal muscles are tense, try to relax the patient and palpate gently again. Having the patient flex the knees is often helpful. Then, palpate by pressing more deeply in all 4 quadrants as you feel for any masses or tenderness, placing one hand on top of the other. Watch closely for signs of an acute abdomen from inflammation of the parietal peritoneum or peritonitis. Signs include abdominal pain with coughing, rigid or board-like abdomen, guarding, rebound tenderness, and percussion tenderness. Percuss the span of the liver. First, locate the midclavicular line. Use a light to moderate percussion strike. Starting at a level below the umbilicus in the right lower quadrant in an area of tympany, percuss up toward the liver. Identify the lower border of dullness in the midclavicular line. Next, identify the upper border of liver dullness. Starting at the nipple line, lightly percuss from lung resonance down toward liver dullness. Measure the span of liver dullness between those 2 points. The normal liver span in men is shown here, and it is generally greater in men than in women. To palpate the liver, place your left hand behind the lower thorax, lifting up the 11th and 12th ribs overlying soft tissues. Place your right hand just below the right upper quadrant, lateral to the rectus abdominis muscles, and well below the lower border of liver dullness.
Breathe deeply for me, please.
Press gently into the abdomen, and as the patient breathes in deeply, try to feel for the liver edge as it moves down to meet your fingertips. If possible, let the liver slip under your finger pads as you feel its anterior surface. You often need to try again, moving your fingertips closer to the costal margin. The hooking technique may also be helpful. Standing to the right of the patient's chest, place the fingers of both hands below the border of liver dullness and press in and up toward the costal margin. Ask the patient to take another deep breath.
Take another deep breath for me, please.
To assess for tenderness when the liver is not palpable, place your left hand flat on the right lower rib cage and gently strike it with the ulnar surface of your right fist. Ask the patient to compare the sensation
Compared to this side.
When a spleen enlarges, it expands anteriorly, downward, and medially, often replacing the tympany of stomach and colon with the dullness of a solid organ. It then becomes palpable below the costal margin. To palpate the spleen to assess its size, reach over and around the patient with your left hand to support the left lower posterior rib cage and overlying structures. Place your right hand below the left costal margin and press in with your fingers toward the spleen.
Take another deep breath.
When the patient takes a deep breath, try to feel the spleen as it comes down to meet your fingertips. The tip of the spleen is palpable in only 5% of normal adults. Alternatively, ask the patient to turn onto the right side with the legs somewhat flexed at the hips. In that position, gravity may bring the spleen forward and to the right into a palpable location. To help detect splenomegaly, an enlarged spleen, percuss the left lower anterior chest wall roughly from the border of cardiac dullness at the 6th rib to the anterior axillary line and down to the costal margin. This is an area called Traub space. As you percuss along this route, note the lateral extent of tympany. If tympany is prominent, especially laterally, splenomegaly is not likely. Then ask the patient to take a deep breath and percuss again. When spleen size is normal, the percussion note usually remains tympanitic.
Spit it out. Okay.
When the spleen is enlarged, tympany often changes to dullness. Dullness is a positive sign. It may be falsely positive, but its presence means you should perform careful palpation. Normally, kidneys are not often palpable, but learning the techniques for examination helps you distinguish enlarged kidneys from other enlarged organs and abdominal masses. To palpate the left kidney, move to the patient's left side and place your right hand behind the patient, just below and parallel to the right 12th rib with your fingertips just reaching the costovertebral angle. Lift, trying to displace the kidney anteriorly. Place your left hand gently in the left upper quadrant, lateral and parallel to the rectus muscle. Now ask the patient to take a deep breath. At the peak of inspiration, press your left hand firmly and deeply into the left upper quadrant, just below the costal margin, and try to capture the kidney between your hands. Ask the patient to breathe out and then stop breathing.
And hold your breath.
Slowly release the pressure of your left hand, feeling at the same time for the kidney to slide back into its expiratory position. If the kidney is palpable, assess its size, contour, and any tenderness. To capture the patient's right kidney, return to the patient's right side and use your left hand to lift up from the back and your right hand to feel deep in the right upper quadrant. Proceed as before. A normal right kidney may be palpable, especially when the patient is thin and the abdominal muscles are relaxed.
Okay, I'm going to examine the aorta for you. Can you take a deep breath in slowly and let it out for me?
To assess the aorta, press the upper abdomen slightly left of midline and feel for the aorta's pulsations. Now, try to assess the width of the aorta, especially in older smokers at risk for abdominal aortic aneurysm. Pressing gently with a hand on each side of the aorta, try to estimate its width. Normally, it should be less than 3 centimeters.
Okay, we're almost done. Now, if I can get you to sit up for me, please.
With the patient sitting up, assess for costovertebral angle tenderness, or CVAT, seen in pyelonephritis. Place the ball of your left hand on each costovertebral angle in turn and strike it with the ulnar surface of your fist. Normally, there is no tenderness over normal kidneys. With practice, you will also be able to utilize special techniques for assessing possible ascites, including percussing outward in several directions from the central area of tympany. 2 additional techniques are testing for shifting dullness, percussing the border of tympany and dullness with the patient supine, then turning the patient onto one side and percussing again, and testing for a fluid wave by tapping one flank sharply with your fingertips while you feel on the opposite flank for an impulse transmitted through the fat. Individuals with more body fat will need 2 sets of hands for this test. You should also be able to assess for possible appendicitis by searching carefully for an area of local tenderness called McBurney's point, which lies 2 centimeters from the anterior superior spinous process of ilium on a line drawn down from the umbilicus. For all your findings, a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
The abdomen is protuberant with active bowel sounds. It is soft and non-tender. No masses or hepatosplenomegaly. The liver span is 7 centimeters and in the right MCL. The edge is smooth and palpable 1 centimeter below the right costal margin.
After practice and further review of this video, make sure you have mastered the learning objectives for examining the abdomen. Your learning objectives for mastering the cardiovascular system examination are to assess the jugular venous pressure and pulsation and the carotid upstroke, to palpate any heaves, lifts, and thrills, to determine the point of maximal impulse, PMI, to auscultate heart sounds and murmurs in 6 positions on the chest wall using the diaphragm and bell of the stethoscope, to identify S1 from S2 and distinguish systole from diastole, to identify extra sounds such as S3 and S4, and to correctly identify valvular murmurs such as mitral regurgitation and aortic insufficiency. For a skilled clinical assessment, you must place your examination of the heart and great vessels in the context of the patient's health history. You must also understand the anatomy of the heart and vascular structures of the neck and chest. Finally, you must be able to accurately describe your findings. Utilizing clinical reasoning, where you move from general observations to more specific conclusions, will lead you to skilled and comprehensive assessment of the patient. For instance, the general appearance of the patient provides many clues to cardiac illness. Note the patient's color, respiratory rate, and level of anxiety. These preliminary observations can be helpful as you begin taking the health history. When talking with the patient, keep in mind the 3 goals of every health history: to establish a trusting and supportive relationship, to gather information, and to offer information. When assessing new patients, you will gather information that will form the basis for a comprehensive written health history. For patients seeking care for a specific complaint, you may prepare a more focused, problem-oriented history. In either case, you will record the patient's chief complaint along with common or concerning symptoms.
So, tell me your special concerns today.
Common or concerning symptoms relating to neck vessels and the heart include chest pain, palpitations, and shortness of breath, orthopnea, or paroxysmal nocturnal dyspnea. Eliciting the patient's concerns before the examination prepares you for an examination that is focused, efficient, and productive.
So, what I'd like you to do now is put on this gown so it opens to the back, and then I'll be back shortly.
Think about the possible meanings of your individual observations, fit them together in a logical pattern, and correlate your cardiac findings with the patient's blood pressure, arterial pulses, venous pulsations, jugular venous pressure, the remainder of your physical examination, and the patient's history. Let's review the three key vascular structures in the neck: the carotid artery, the internal jugular vein, and the external jugular vein. The carotid artery is deep to the sternomastoid muscle. The internal jugular vein lies beneath the sternomastoid muscle adjacent to the carotid artery. The internal jugular vein is not normally visible. The external jugular vein runs at an angle along the sternomastoid muscle toward the clavicle. After comprehensive hand hygiene, you are ready for the physical examination. Jugular venous pressure, or JVP, is a measurement of the highest oscillation point, or meniscus, of the jugular venous pulsations. This measurement reflects pressure in the right atrium, that is, central venous pressure. The JVP also provides valuable information about the patient's volume status and cardiac function. Estimating the patient's JVP is one of the most important and frequently used skills of physical examination, and often the first step in your cardiovascular assessment. The JVP is best assessed from pulsations in the right internal jugular vein. Adjust the head of the examining table to 30 degrees. With the patient supine, place the patient's head on a pillow just to the top of the shoulders to relax the sternomastoid muscles. Then adjust the patient's gown and drape as necessary. Examine both sides of the neck. Then turn the patient's head slightly to the left, since the physical examination is conducted from the patient's right side. Focusing on the right side, identify the external jugular vein. Then find the internal jugular venous pulsations. If necessary, raise or lower the head of the bed until you can see the oscillation point of the internal jugular venous pulsations in the lower half of the neck. Look for the oscillation point along the sternomastoid muscle between the clavicle and the angle of the jaw, or just posterior to the sternomastoid. Internal jugular pulsations have a soft, undulating quality, usually with 3 elevations per heartbeat, 2 of which are visible, and 2 troughs, whereas the carotid pulse has a more vigorous thrust with a single outward component. Internal jugular pulsations are rarely palpable, whereas the carotid pulse is almost always palpable. Internal jugular pulsations are eliminated by light pressure on the vein just above the clavicle, whereas the carotid pulse is not eliminated by the pressure. The level of internal jugular pulsations changes with position. In a euvolemic patient, the level in the neck drops as the patient becomes more upright, whereas the carotid pulse is unchanged by position. Finally, the level of internal jugular pulsations usually falls with inspiration, whereas the carotid pulse is not affected by inspiration. Measure the oscillation point of pulsation in the right internal jugular vein using the following technique. Extend an elongated rectangular object, such as a 3x5 card, from the meniscus point of pulsation, while extending a centimeter ruler vertically from the sternal angle, making a right angle. To establish the true vertical and horizontal lines, place your ruler on the sternal angle and line it up with a vertical line in the room. Then place your card or other rectangular object at an exact right angle to the ruler. This constitutes your horizontal line. Make sure one edge of the card is at the point of oscillation of the jugular venous pulsations, making sure to keep the card horizontal. Read the vertical distance where the card crosses the ruler. This measurement identifies the jugular venous pressure, or JVP, the vertical distance in centimeters above the sternal angle where your card crosses the ruler. Round your measurement off to the nearest centimeter. In this patient, the JVP is about 2 centimeters above the sternal angle. Venous pressure is elevated above normal when it measures at greater than 3 to 4 centimeters above the sternal angle, with the bed elevated to 30 degrees, or more than 7 to 8 centimeters in total distance above the right atrium. These steps allow you to make an accurate measurement of the JVP that is important for assessing the intravascular volume status in euvolemic, hypervolemic, or hypovolemic patients. In hypervolemic patients, the JVP can be as high as the angle of the jaw. In hypovolemic patients, the JVP may be below the sternal angle. Next, assess the carotid pulse. The carotid pulse provides valuable information about valvular heart disease and is especially useful for detecting aortic stenosis or aortic insufficiency. Your assessment will include both palpation to assess the amplitude and contour of the carotid upstroke, and auscultation for the presence or absence of bruits from turbulent blood flow. Inspect and palpate both the right and left carotid arteries, then compare. However, do not press on both carotid arteries at once, since syncope may ensue. Place your index and middle fingers, or your thumb, on the right carotid artery in the lower third of the neck. Press just inside the medial border of a well-relaxed sternomastoid muscle, roughly at the level of the cricoid cartilage. Slowly increase pressure until you feel a maximal pulsation. Then slowly decrease pressure until you best sense the arterial pressure wave and contour. Try to assess the amplitude of the pulse. This correlates reasonably well with the pulse pressure. This illustration represents the contour of the pulse wave, that is, the speed of the upstroke, the duration of its summit, and the speed of the downstroke. The normal upstroke is brisk, smooth, and rapid, and follows S1 almost immediately. The summit is smooth, rounded, and roughly mid-systolic. The downstroke is less abrupt than the upstroke. The more familiar you are with normal readings, the easier it will be to detect abnormalities, such as a pulse that has a bounding upstroke, aortic insufficiency. These and other abnormalities of arterial pulse and pressure waves are important indicators of abnormalities of the aortic valve and cardiac function.
Okay, just turn your head a little bit and hold your breath.
After palpating the carotid arteries, listen carefully over both arteries with the diaphragm of your stethoscope. Some examiners use the bell. Ask the patient to hold breathing for a moment so that breath sounds do not obscure the sound of turbulent flow. Listen for a bruit, which is a whooshing murmur-like sound, often from atherosclerotic narrowing of the carotid artery. A bruit sounds like this. You should listen for bruits over the carotid arteries in middle-aged or older adults, or if you suspect cerebrovascular disease. Now turn to the cardiac examination and review the important features of cardiac anatomy. The right atrium forms the right border of the heart. The left atrium is mostly posterior. Neither the right nor the left atrium can be examined directly. Above the heart lie the great vessels. The pulmonary artery arises from the right ventricle and quickly bifurcates into its left and right branches. The aorta arises from the left ventricle. Most of the anterior surface of the heart is made up of the right ventricle. The left ventricle lies to the left of and behind the right ventricle. It forms the left border of the heart and produces the apical impulse. During systole, the left ventricular apex typically generates a brief tapping apical impulse, usually found in the left fifth interspace, about 7 to 9 centimeters from the midsternal line. The impulse measures about the size of a quarter, roughly 1 to 2.5 centimeters in diameter. Your examination of the heart consists of inspection, palpation, and auscultation. Let's begin with inspection and palpation. Stand at the patient's right side. Have the patient remain supine with the upper body raised to 30 degrees. First, inspect the anterior chest, noting any heaves or lifts. None are observed here. Careful inspection may also reveal the location of the apical impulse. Later in the examination, you will palpate to more clearly identify the apical impulse. Now proceed with palpating the chest wall. First palpate for heaves or thrills using your finger pads. Hold them flat or obliquely on the body surface as you palpate in the right and left second interspaces along the left sternal border and in the apical area. Ventricular impulses may heave or lift your fingers, suggesting ventricular dilatation. None is seen here. Then check for thrills by pressing the ball of your hand firmly on the chest in these same locations. If subsequent auscultation reveals a loud murmur, go back and check for thrills over that area again. Thrills suggest underlying turbulent blood flow and change how you will grade related heart murmurs. Next, identify the apical impulse. The apical impulse represents the brief pulsation of the left ventricle as it moves anteriorly during contraction and touches the chest wall. Note that in most examinations, the apical impulse is the point of maximal impulse, or PMI. However, some pathologic conditions, an enlarged right ventricle for example, may produce a pulsation that is more prominent than the apical impulse. Using the palmar surfaces of several fingers, then for finer assessments your fingertips, followed by one finger alone, palpate to confirm the characteristics of the apical impulse. You will note its location, diameter, and amplitude. Identify the location of the apical impulse by the interspaces in which you feel it, and by its distance in centimeters from the midsternal line. If you experience difficulty locating the apical impulse, ask the patient to tip or partially roll onto his left lateral side, that is, into the left lateral decubitus position. Palpate again using the palmar surfaces of several fingers. Measure the diameter of the impulse in centimeters. Feel for the amplitude of the apical impulse. It is usually small and feels like a gentle tap. A diffuse apical impulse suggests left ventricular dilatation, often found in congestive heart failure. A sustained tapping impulse that lifts your finger off the chest wall suggests left ventricular hypertrophy, found in hypertension and aortic stenosis. With experience, you will learn to feel the apical impulse in a high percentage of patients. Next, feel for a right ventricular impulse at the lower left sternal border. While keeping one finger in the third interspace, place additional fingertips in the fourth and fifth interspaces. Then, feel for the right ventricular impulse in the epigastric or subxiphoid area.
And I'd like you to take a breath in.
If the patient's chest has an increased antero-posterior diameter, palpate for the right ventricular impulse high in the epigastric area, where it may be easier to feel. This can be seen in COPD due to increased right ventricular pressure and hypertrophy from pulmonary hypertension. Auscultation of heart sounds is an important skill that leads directly to important clinical diagnoses. Before auscultating the heart, let's review normal heart sounds. Closure of the heart valves creates a pair of audible heart sounds. The first sound, S1, arises from closure of the mitral valve. Tricuspid valve closure may also contribute to S1. The second sound, S2, arises from closure of the aortic valve. Pulmonic valve closure may also contribute to S2. This graphic represents the ventricular systole that occurs between S1 and S2. Ventricular diastole occurs between S2 and the next S1. The fact that diastole usually lasts longer than systole is helpful in distinguishing the two sounds. When auscultating, it's important to know your stethoscope. The diaphragm is better for detecting higher-pitched sounds, such as S1 or S2, the murmurs of aortic and mitral regurgitation, and pericardial friction rubs. The bell is more sensitive to low-pitched sounds, such as S3 or S4, and the murmur of mitral stenosis. When auscultating the heart, remember to correlate your findings with the patient's jugular venous pressure and carotid pulse. For example, if there is a diffuse PMI and an S3 suggesting congestive heart failure, look for an elevated JVP. You will listen for S1 and S2 in each of the 6 listening areas. In the aortic area, in the right second interspace close to the sternum. In the pulmonic area, in the left second interspace close to the sternum. In the third left interspace. In the tricuspid area, in the left fourth and left fifth interspaces. And in the mitral area at the apex.
I'm going to listen to your heart over various areas of your chest.
To begin the auscultation sequence, adjust your stethoscope so that you listen through the diaphragm. Begin listening in the aortic area, at the right second interspace, close to the sternum. Starting in the right second interspace helps orient you to the cardiac cycle. Note the cardiac rate and rhythm. Normally the rate is 60 to 100 beats per minute, and the rhythm is regular. Identify S1 and S2. In the aortic area, S2 is usually louder than S1. S2 is also usually louder than S1 in the pulmonic area.
Okay, now just take a breath in and out.
Still listening in the pulmonic area, try to identify the inspiratory splitting of S2 into its 2 components. Its first component, A2, is from aortic valve closure. Its second component, P2, comes from pulmonic valve closure. This physiologic split of S2A and S2P normally occurs during inspiration. During expiration, however, these 2 components are fused into a single sound, S2. Listen again. S2 usually diminishes in intensity, while S1 becomes louder as you proceed down through the third interspace and into the tricuspid and mitral areas. Now switch to the bell of the stethoscope. Listen next along the lower left sternal border in the left fourth and fifth interspaces. Then listen at the apex.
I'd like to listen to your heart in another position. So could you tip over onto your left side, please?
To improve your ability to hear S3, S4, and the murmur of mitral stenosis, place the patient in the left lateral decubitus position. Have the patient roll partway onto his left side. This brings the left ventricle closer to the chest wall and makes low-pitched sounds more audible. Then, recheck the position of the apical impulse and place the bell lightly over that location. If the patient had an audible S3, it would sound like this. Now, notice how the third heart sound disappears when the bell is placed more firmly on the chest wall. Listen again with light pressure. Murmurs are differentiated from heart sounds by their longer duration. If you detect a heart murmur, you must learn to assess its timing, shape, location of maximal intensity, and radiation, grade its intensity, and assess its pitch and quality. Palpating the carotid pulse as you listen can help you with timing. First, decide if you are hearing a systolic murmur, falling between S1 and S2 and coinciding with the carotid upstroke, a diastolic murmur, falling between S2 and S1, falling before or after the carotid upstroke. Murmurs are classified according to where they fall in systole and diastole. Palpating the carotid upstroke as you listen to the murmur is an important tip that helps you decide if the murmur is systolic or diastolic. Systolic murmurs can be early, mid, or late systolic, or even pansystolic. For example, a mid-systolic murmur, heard in physiologic flow murmurs, or the crescendo-decrescendo murmur of aortic stenosis, begins after S1 and stops before S2. Brief gaps are audible between the murmur and the heart sounds. Listen carefully for the gap just before S2. On the other hand, a pansystolic murmur, heard in mitral regurgitation, starts with S1 and stops at S2 without a gap between murmur and heart sounds. A mid-diastolic murmur, as in mitral stenosis, starts a short time after S2 and may follow an opening snap. The shape of a murmur is determined by its intensity over time. A crescendo murmur grows louder. A decrescendo murmur grows softer. A plateau murmur has the same intensity throughout. The location of maximal intensity is determined by the site where the murmur originates. Find the location by exploring the area where the murmur is loudest. Describe where you hear it best in terms of the interspace, and describe the murmur's position relative to the sternum, the apex, or the midsternal, midclavicular, or one of the axillary lines. Radiation, also referred to as transmission from the point of maximal intensity, reflects not only the site of origin, but also the intensity of the murmur and the direction of blood flow. Auscultate the area around a murmur and determine where else you can hear it. Intensity is usually graded on a 6-point scale and expressed as a ratio. The numerator describes the intensity of the murmur wherever it is loudest, and the denominator, by convention, is 6, indicating the scale you are using. Using the 6-point scale, grade 1 indicates a murmur that is very faint and heard only after the listener has tuned in. It may not be heard in all positions. A grade 2 murmur is quiet, but heard immediately after placing the stethoscope on the chest. A grade 3 murmur is moderately loud, and grades 4, 5, and 6 by definition have an accompanying palpable thrill. The quality of a murmur is described in terms such as harsh, blowing, as in aortic regurgitation, musical, as in some murmurs of mitral valve prolapse, or rumbling, as in mitral stenosis. To better detect the more subtle diastolic murmurs of aortic regurgitation and mitral stenosis, you should routinely use two maneuvers. The first maneuver is performed with the patient sitting up and leaning forward. This maneuver enhances detection of aortic regurgitation by moving the left ventricle closer to the chest wall. Ask the patient to exhale completely and hold his breath out.
Take a big breath in, blow it all out and stop.
Using the diaphragm of the stethoscope, listen at the left second interspace and down the left sternal border to the apex for the high-pitched, soft-blowing decrescendo diastolic murmur of aortic regurgitation. If the patient had this murmur, it would sound like this. The second maneuver helps you detect the murmur of mitral stenosis. Have the patient change to the left lateral decubitus position. Auscultating in this position enhances detection of the more subtle opening snap and diastolic rumble of mitral stenosis. A clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care. For a healthy patient, your write-up might include language such as,
Jugular venous pressure is 3 centimeters above the sternal angle with head of bed elevated to 30 degrees or 7 centimeters above the right atrium. Carotid upstrokes are brisk without bruits.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining the cardiovascular system. The examination of infants differs from adult examinations and even those of older children. An examination of this nature will benefit from an efficient sequence of examination, plus the clinician's flexibility to respond to the infant's level of cooperation. You will find that the infant's level of development affects the degree of cooperation. A 3-month-old infant will normally lift the head and clasp the hands. By 6 months, infants normally roll over, turn to voices, and reach for objects, including those in your hands. A 1-year-old may be standing and putting everything in their mouth, including any equipment you might set down within their reach. Temperaments vary. Some infants respond positively to new stimuli, including you. Others may respond to you intensely or negatively. You can increase the chances of obtaining cooperation by considering the following tips. Try to examine infants 1 to 2 hours after feeding, when they are most responsive and liable to be less cranky. Ask the parent about the infant's strengths in order to elicit useful developmental and parenting information. Begin by discussing with the parents any concerns or questions they may have. This is also a time to talk about strategies to optimize the health and well-being of their infant. With the patient's health history in mind, and after good hand hygiene, you are ready for the physical examination. Examine the infant in the presence of the parents, as parents can often help to calm a restless or screaming baby. You can examine the infant in the parent's lap if needed, but an examination table or crib is optimal. Perform a general survey, inspecting the patient closely, literally from head to toe, in order to form impressions for your written assessment. During the general survey, observe the quality of parent-child interactions. Also look for signs of stress or depression in parents, which may place the child at risk and sometimes can indicate an increased risk for child abuse or neglect. Approach the infant gradually, using a toy or object for distraction. Speak softly to the infant or mimic the infant's sounds to attract attention. Don't expect to do a head-to-toe exam in a specific order. Take what the infant gives you and save the mouth and ear exam for last. In general, you will perform non-disturbing maneuvers early in the examination and potentially distressing maneuvers near the end. Follow the general survey with an assessment of somatic growth. Growth is one of the most important indicators of a child's health, and deviations from normal may be an early sign of an underlying problem. When assessing growth, compare your findings with normal values according to the child's age and sex. The most important tools for assessing somatic growth are growth charts. Growth charts display a series of lines that enable you to establish percentile rankings for your patients, indicating their growth relative to other children of the same chronologic age. For safety reasons, it is recommended that pediatric examination tables be placed flush against the examination room wall. For the infant, height is measured as body length. Direct measurement using a tape measure is inaccurate. For a more accurate measurement, place the baby supine on a measuring board or tray, holding the patient still with hips and knees fully extended. Weigh infants directly with an infant scale. Infants should be naked or clothed only in a diaper, in which case the diaper should be weighed separately and that weight subtracted from the overall measurement. Head circumference should always be measured during the first 2 years of life. This measurement reflects the rate of growth of the cranium and the brain. Place the measuring tape over the occipital, parietal, and frontal prominences to obtain the maximum circumference. While blood pressure is routinely measured in children older than 2 years, it can also be obtained from infants, but only if indicated. You will need skills in distraction or play to help obtain this measurement. The most easily used measure of systolic blood pressure in infants is the Doppler method, which detects arterial blood flow vibrations, converts them to systolic blood pressure levels, and transmits them to a digital readout device. You may have trouble obtaining an accurate pulse rate in squirming infants. The best strategy is to palpate either the femoral arteries in the inguinal area or the brachial arteries in the antecubital fossa, or to auscultate the heart. This measurement is important because the heart rate of infants is more sensitive to the effects of illness, exercise, and emotion than that of adults. The respiratory rate in infants has a greater range compared to adults, and in fact may vary considerably from moment to moment, with alternating periods of rapid and slow breathing. In infants, the normal rate ranges between 30 and 60 breaths per minute. Ideally, the respiratory pattern should be observed for at least 60 seconds to assess both the rate and pattern. Because fever is so common in children, obtain an accurate body temperature when you suspect infection. Auditory canal temperatures are considered accurate. The technique for obtaining rectal temperature is relatively simple. Place the infant or child prone on the examining table, on the parent's lap, or on your own lap. Separate the buttocks with the thumb and forefinger on one hand, and with the other hand, gently insert a well-lubricated rectal thermometer to a depth of 2 to 3 centimeters. Keep the thermometer in place for at least 2 minutes. The average rectal temperature is higher in infancy and early childhood, usually 99 degrees Fahrenheit until after 3 years, and may fluctuate as much as 3 degrees during a single day. As you proceed through the examination, and as opportunity arises, examine the skin of the infant carefully to identify both normal markings and potentially abnormal ones. In infants, the skin texture is soft and smooth because it is thinner than the skin of older children. A response to cooling and chronic exposure to radiant heat can occasionally produce cutis marmorata, a lattice-like bluish mottled appearance on the trunk, arms, and legs. Other common skin conditions and rashes include acrocyanosis, milia, miliaria rubra, erythema toxicum, and pustular melanosis. Note any birthmarks in the infant and palpate to assess the degree of hydration or turgor. Roll a fold of loosely adherent skin between your thumb and forefinger to determine its consistency. In well-hydrated infants, the skin returns to its normal position immediately upon release. Normal physiologic jaundice occurs in half of all infants, appearing on the 2nd or 3rd day of life, peaking at about the 5th day, and usually disappearing within 1 week. Pressing the red color from the skin allows better recognition of the yellow of jaundice. This infant displays no sign of jaundice. When examining the head of the infant, you'll find that the bones of the skull are separated from one another by membranous tissue spaces called sutures. The areas where the major sutures intersect in the anterior and posterior portions of the skull are known as fontanelles. Palpate the sutures and fontanelles carefully, with the baby sitting quietly or being held upright. The fullness of the fontanelles reflects intracranial pressure. In normal infants, the anterior fontanelle is soft and flat. A full anterior fontanelle with increased intracranial pressure can be seen when a normal baby cries or vomits. Pulsations of the fontanelle reflects the peripheral pulse. Assess the symmetry of the skull. Several conditions can cause asymmetry of the skull in newborns and infants. Some are normal or benign, while others reflect underlying pathology. Examine the skull shape from behind. Asymmetry of the cranial vault, or positional plagiocephaly, occurs when an infant lies mostly on one side, resulting in a flattening of the parieto-occipital region on the dependent side. It normally disappears as the baby becomes more active. But plagiocephaly may also reflect injury to the sternocleidomastoid muscle, or premature closure of the sutures, craniosynostosis. Next, check the face of the infant for symmetry. Then, concentrate on forming an overall impression of the facies. It is often helpful to compare the face of the baby with the face of the parent. A systematic assessment of a child with abnormal appearing facies can identify specific syndromes. Percuss the cheek to check for Chvostek's sign, which is present in some metabolic disturbances and occasionally in normal infants. Percuss at the top of the cheek, just below the zygomatic bone in front of the ear, using the tip of your index or middle finger. When assessing the infant's eyes, use subdued room lighting, because bright light causes infants to blink. Newborns keep their eyes closed except during brief awake periods. If you attempt to separate their eyelids, they will tighten them even more. By 1 month of age, an infant should be able to fix on objects such as your face and follow a bright light, provided you catch the baby during an alert period. Examine the infant for eye movements. Hold the baby upright, supporting the head. Rotate yourself with the baby slowly in one direction. This usually causes the baby's eyes to open, allowing you to examine the sclerae, pupils, irises, and extraocular movements. During the first few months of life, some infants have intermittent crossed eyes or intermittent laterally deviated eyes. This can be normal. Look for abnormalities or congenital problems in the sclerae and pupils. Subconjunctival hemorrhages are common in newborns. The eyes of many newborns are edematous from the birth process. Pupillary reactions can be observed either by response to light or by covering each of the infant's eyes with your hand and then uncovering them. Inspect the irises carefully for abnormalities and examine the conjunctiva for swelling or redness. Then, try to use your ophthalmoscope to examine the red retinal fundus reflex. Failure to see a red or orange reflex may indicate an abnormality. Set the ophthalmoscope to 0 diopters and view the pupil from 10 to 12 inches away. Normally, a red or orange color is reflected from the fundus through the pupil. The cornea can normally be seen at plus 20 diopters, the lens at plus 15 diopters, and the fundus at 0 diopters. Also, look carefully for retinal hemorrhages. Examination of the infant's ears is important because many abnormalities can be detected, including structural problems, otitis media, and hearing loss. Note the position of the ears in relation to the eyes. An imaginary line drawn across the inner and outer canthi of the eyes should cross the pinna or auricle. If the pinna is below this line, then the infant has low-set ears. While this may be normal, it may also be a sign of a congenital syndrome. The infant's ear canal is directed downward from the outside, so you must pull the auricle downward, not upward, to get the best view of the eardrum. Test for hearing using the acoustic blink reflex, a blinking of the infant's eyes in response to a sudden sharp sound. You should be able to produce this reflex by snapping your fingers or using a bell, beeper, or other noise-making device approximately 1 foot from the infant's ears. Be sure that you are not producing an airstream that may cause the infant to blink. This reflex may disappear after the first 2 or 3 times within a brief period because of a phenomenon known as habituation. The most important component of the examination of the infant nose is to test patency of the nasal passages. You do this by gently occluding each nostril alternately. Because infants are nasal breathers, they should easily tolerate this gentle maneuver. Do not occlude both nostrils at once, however, which would cause considerable stress. To inspect the nose, use a wide speculum and ensure the nasal septum is midline. Palpation of the sinuses of newborns is not helpful. To inspect the mouth and pharynx of infants, use a tongue blade and a light, as well as palpation. One method of examination utilizes the parent to hold the infant's head and arms. Palpate the upper hard palate to make sure it is intact. You may notice small pearl-like cysts called Epstein's pearls along the alveolar ridges or centrally on the hard palate. Epstein's pearls disappear within 1 or 2 months. You may see a whitish covering on the tongue. If this coating has been caused by milk, it can easily be removed by scraping or wiping it away. Try to distinguish milk from thrush, which is also commonly seen on the buccal and gingival surfaces. Pharynx of the infant is best seen while the infant is crying. Listen to the quality of the infant's cry. It should be lusty and strong. You will likely have difficulty using a tongue blade because it produces a strong gag reflex. Do not expect to be able to visualize the tonsils. Begin examination of the infant's neck by palpating. Because the necks of infants are short, it is best to palpate them in the supine position. Palpate the lymph nodes of the neck and assess for any additional masses, such as congenital cysts, including branchial cleft cysts, thyroglossal duct cysts, or cystic hygromas. Next, check the position of the thyroid cartilage and trachea. In newborns, palpate the clavicles and look for evidence of fracture. Carefully assess respirations and pattern of breathing. An important tip is not to rush to the stethoscope, but rather to observe the infant carefully and note respiratory rate, color, nasal component of breathing, and audible breath sounds. including nasal flaring, grunting, audible wheezing, or retractions, known as chest indrawing. Chest indrawing is the inward movement of the ribs during inspiration. Any of these signs of work when breathing indicate respiratory pathology. Percussion is not helpful in the examination of the chest of infants, as the infant's chest is hyperresonant throughout. So assess tactile fremitus by palpation. Place your hand on the infant's chest when the infant cries or makes noise. Place your hands or fingertips over each side of the chest and feel for symmetry in the transmitted vibrations. Next, begin auscultation. Breath sounds are louder and harsher in infants than in adults because the stethoscope is closer to the origin of the sounds. Also, it is often difficult to distinguish transmitted upper airway sounds from sounds originating in the chest. Upper airway sounds tend to be loud, transmitted symmetrically throughout the chest, and loudest as you move your stethoscope toward the neck. They are usually inspiratory, coarse sounds. Lower airway sounds are loudest over the site of pathology, are often asymmetric, and may occur during expiration. Expiratory sounds are generally from an intrathoracic source, while inspiratory sounds can arise from an extrathoracic airway, such as the trachea, or an intrathoracic source. The characteristics of the breath sounds, such as vesicular and bronchovesicular, and of the adventitious lung sounds, such as crackles, wheezes, and rhonchi, are the same as those for adults, except that they may be more difficult to distinguish in infants and often occur together. Before examining the heart itself, carefully observe the skin for cyanosis. The best place to ensure that the infant is pink is to look in the mouth. A true pink, the color of a strawberry, is normal, while cyanosis appears more like the deeper red of a raspberry. Acrocyanosis is important to detect. While it may be a normal response to exposure to cold air, it may also reflect congenital cardiac abnormalities as well as respiratory diseases. Observe the infant for general signs of health. The infant's nutritional status, responsiveness, happiness, and irritability are all clues that may be useful in evaluating cardiac disease. Observe the respiratory rate and pattern to help distinguish the degree of illness and cardiac versus pulmonary disease. While respiratory disease tends to cause work of breathing, cardiac disease in infants tends to cause peaceful tachypnea. Palpate the peripheral pulses. The brachial artery pulse in the antecubital fossa is easier to feel than the radial pulse at the wrist. Feel the femoral pulses, which lie at the midline just below the inguinal crease, between the iliac crest and the symphysis pubis. This is particularly challenging in squirmy, chubby infants, but it is important to assess because coarctation of the aorta can cause absent femoral pulses on the affected side. One trick is to flex the infant's thighs. The infant will likely stretch them out a bit and allow you to palpate in the inguinal canal. You should also try to palpate the dorsalis pedis and posterior tibial pulses, although these may be difficult to feel. Note that the point of maximal impulse is often not palpable in infants. Next, place your hand on the chest to feel for thrills. The rough, vibrating turbulence of thrills within the heart or great vessels is quite rare in infants. You can evaluate the heart rhythm more easily by listening to the heart rather than by feeling the peripheral pulses. Auscultate using the diaphragm and the bell of your stethoscope to evaluate the S1 and S2 heart sounds carefully. They are normally crisp. You can usually hear the second sounds, or S2, at the base separately, but they should fuse into a single sound in deep expiration. A split S2 may be detected in neonates who are quiet or asleep. Hearing a split S2 reduces the likelihood of serious congenital cardiac defects. If S2 is detected, listen for the intensity of the aortic or first component, which is normally louder than the second component, the pulmonic sound. Third heart sounds that are low-pitched and early diastolic may be detected best at the lower sternal border or right ventricular area. They reflect rapid ventricular filling and not disease. Fourth heart sounds are not often heard in children and are low-frequency late diastolic sounds occurring just before the first heart sound. You might even hear an apparent gallop in the presence of a normal rate and rhythm. This is normal in infants. Remember that infants breathe rapidly, so you will need to mentally subtract the sounds of respiration from the heart sounds. One of the most challenging aspects of the cardiac examination of infants is the evaluation of heart murmurs. Characterize heart murmurs by noting their specific location. For instance, locating a murmur in the left sternal border is less helpful than describing the location as the left upper sternal border. Listen for systolic or diastolic murmurs as well as third heart sounds. Fourth heart sounds are rare in newborns. Most children will have one or more functional or benign heart murmurs at some point in their childhood. With time and practice, you will improve your ability to differentiate between these murmurs and the unusual or pathologic ones. While examining the breasts of both the male and female newborn, you'll find they are often enlarged as a result of the effects of maternal estrogen. Such enlargement may last several months. The breasts also may be engorged with a white liquid, sometimes colloquially called witch's milk. This finding may last for the first week or two of life. Inspect the abdomen of the infant with the baby lying supine. The normal infant's abdomen is protuberant as a result of poorly developed abdominal musculature. In a very young infant, inspect the umbilical cord to detect abnormalities. Normally, there are 2 thick-walled umbilical arteries and 1 larger thin-walled umbilical vein, which is usually located at 12 o'clock. Look for any redness of the skin around the umbilicus, which would be abnormal and could signify infection. Swelling around the umbilicus is probably due to umbilical hernias, which are detectable at a few weeks of age and tend to disappear by 1 year. You may notice a diastasis recti in many normal infants. This is a separation of the 2 rectus abdominis muscles, causing a midline ridge, especially on contraction of the abdominal muscles. This is a benign condition in most cases. As in adults, auscultate the abdomen prior to palpation. You may note active tympanic sounds because of the infant's propensity to swallow air. It is easy to palpate an infant's abdomen because infants like being touched. A useful technique to relax the infant is to hold the legs flexed at the knees and hips with one hand while palpating the abdomen with the other. You may also want to request assistance from a parent or use a pacifier or bottle to quiet the infant in this position. Start gently palpating the liver in infants low in the abdomen, moving upwards with your fingers. This technique helps you avoid missing an extremely enlarged liver that extends down into the pelvis. With a careful examination, you can feel the liver edge in most infants 1 to 2 centimeters below the right costal margin. It is more difficult to feel the spleen than the liver. The spleen is soft with a sharp edge and projects downward like a tongue, normally 1 to 2 centimeters under the left costal margin. You may be able to palpate the kidneys of infants by carefully placing the fingers of one hand in front of and those of the other hand behind each kidney. In the newborn female, the genitalia will be prominent as a result of the effects of maternal estrogen. The labia majora and minora have a dull pink color in light-skinned infants and may be hyperpigmented in dark-skinned infants. Examine the different structures systematically, including the size of the clitoris, the color and size of the labia majora, and any rashes, bruises, or external lesions. Separate the labia majora at their midpoint with the thumb of each hand and inspect the urethral orifice and labia minora. Assess the hymen, which is a thickened avascular structure with a central orifice covering the vaginal opening. Begin examination of the infant male genitalia with inspection. With the infant supine, note the appearance of the penis, testes, and scrotum. Then, unless the infant's penis has been circumcised, examine the foreskin, which completely covers the glans penis. You may be able to retract the foreskin of the infant just enough to visualize the external urethral meatus. Do not retract the foreskin forcefully. Examine the shaft of the penis, noting abnormalities. Make sure the penis is straight. Inspect the scrotum and testes, making sure you can feel both testes. Note any swelling within the scrotal sac and try to differentiate it from the testes. Familiarizing yourself with the appearance of the genitalia at different ages will help you recognize normal variations from subtle abnormalities. For infants, the rectal examination consists of visual inspection of the anus. Digital examination is not routinely performed unless pathology is suspected. Much of the musculoskeletal examination focuses on detection of congenital abnormalities, particularly in the hands, spine, hips, legs, and feet. Combine the musculoskeletal examination with the developmental and nervous system examinations. The infant's hands are clenched because of the palmar grip reflex. Extend the fingers carefully and inspect, noting any defects. Palpate along the clavicle, noting any lumps, tenderness, or crepitus that may indicate a fracture. Carefully inspect the spine. Major defects such as a meningomyelocele will be obvious, but look also for subtle abnormalities, including pigmented spots, hairy patches, or deep pits, particularly along the midline. Palpate the spine in the lumbosacral region. Examine the infant's hips carefully for signs of dislocation. Two techniques are especially helpful. For the Barlow test, hold the legs as shown and rotate your hands outward, seeing if the femoral head feels stable or moves laterally. Movement of the femoral head signifies laxity and a dislocatable hip. For the Ortolani test, again hold the legs as shown and rotate your hands the other way, inward, until each knee touches the table. A palpable movement of the femoral head back into place is abnormal. It is important to examine the legs and feet to detect developmental abnormalities. Assess symmetry, bowing, and torsion of the legs. There should be no discrepancy in leg length. Some normal infants exhibit twisting or torsion of the tibia inwardly or outwardly on the longitudinal axis. Parents may be concerned about a toeing in or toeing out of the foot and an awkward gait in toddlers, all of which are usually normal. Tibial torsion corrects itself during the second year of life after months of weight bearing. Finally, examine the feet of the infant. At birth, the feet may appear deformed from retaining intrauterine positioning, often being turned inward. Manipulate the affected foot. A normal foot should be easy to correct to neutral and even to an overcorrected position. Scratch or stroke along the outer edge of the foot to see if it assumes a normal position. The normal infant's foot has several features that, while they may initially concern you, are benign. The foot appears flat because of a plantar fat pad. There is often inversion of the foot, elevating the medial margin. The infant may exhibit adduction of the forefoot without inversion, or even adduction of the entire foot. Each of these normal variants tends to resolve within 1 or 2 years. The examination of the nervous system in infants includes techniques specific to their particular age. Because neurologic abnormalities in infants often present as developmental abnormalities, these two examinations need to proceed together. First, assess the mental status during alert periods. If the baby is transiently too drowsy, return at a later time. Assess motor function and tone by carefully watching the infant's position at rest and then testing resistance to passive movement. Assess tone as you move each major joint through its range of motion, noting any spasticity or flaccidity. Hold the baby in your hands to determine if the tone is normal, increased, or decreased for age. You can test for the infant's sensory function only in a limited way. Test for pain sensation by flicking the infant's palm or sole with your finger. Observe for withdrawal, arousal, or change in facial expression. Do not use a pin to test for pain. Testing an infant's cranial nerves requires special methods that differ from those used for older patients. Cranial nerve 1, which mediates sense of smell, is difficult to test in infants. Cranial nerve 2 mediates vision, while cranial nerves 3, 4, and 6 mediate extraocular movement. These nerves can be tested by having the baby regard your face or a moving toy that has no sound. Look for facial response and tracking. Cranial nerves 2 and 3 control response to light. To test, raise the baby to a sitting position to open the eyes. Use a light and test for optic blink reflex. You may also use the otoscope, without a speculum, to assess pupillary response. Cranial nerve 5 can be assessed by testing the rooting reflex and the sucking reflex. Cranial nerve 7 innervates all muscles of facial movement and expression. Observe the baby crying and smiling while you assess symmetry of the face and forehead. Cranial nerve 8 mediates hearing and vestibular function. Test acoustic blink reflex and tracking in response to sound. Cranial nerves 9 and 10 mediate the sensory and motor functions of the palate, pharynx, and larynx. These nerves are assessed by observing the infant's coordination during swallowing and by testing for a gag reflex. Cranial nerve 11 innervates the sternomastoid muscles and upper trapezius muscles and is assessed by observing the symmetry of the infant's shoulders. Cranial nerve 12 mediates motor functions of the tongue, affecting articulation of words. Observe coordination of swallowing, sucking, and tongue thrusting. The deep tendon reflexes are variable in newborns and infants because the corticospinal pathways are not fully developed. Their exaggerated presence or their absence has little diagnostic significance unless this response is different from results of previous testing or unless extreme responses are observed. To elicit deep tendon reflexes of the biceps and quadriceps, use the same techniques as you would for an adult, substituting your index or middle fingers for the neurologic hammer. However, the triceps, brachioradialis, and abdominal reflexes are difficult to elicit before 6 months of age. Although a normal flexion plantar response is obtained in 90% of infants, a positive Babinski response to plantar stimulation, that is dorsiflexion of the big toe and fanning of the other toes, can be elicited in some normal infants until 2 years of age. Try to elicit the ankle reflex by grasping the infant's malleolus with one hand and abruptly dorsiflex the ankle. You may note rapid rhythmic plantar flexion of the foot in response to this maneuver. Up to 10 beats can be normal, but 1 to 2 beats are most common. The infant's developing central nervous system can be evaluated by assessing infantile automatisms called primitive reflexes. These develop during gestation, are generally demonstrable at birth, and disappear at defined ages. A few of the more important primitive reflexes include the palmar grasp reflex. Place your fingers into the baby's hands and press against the palmar surfaces. In infants up to 3 to 4 months old, the baby should flex all fingers to grasp your fingers. The rooting reflex. Stroke the perioral skin at the corners of the mouth. In infants up to 4 to 6 months old, the mouth should open, and the baby should turn the head toward the stimulated side and suck. The Moro or startle reflex. Hold the infant supine, supporting the head, back, and legs. Abruptly lower the entire body about 2 feet. In infants up to 4 to 6 months old, the arms should abduct and extend, hands open, while the legs flex. The infant may cry. Abnormalities in these primitive reflexes merit more intensive investigation. There are standardized developmental screening instruments which illustrate the key developmental milestones that an infant normally reaches. These charts can aid you in determining which age-specific developmental tasks to evaluate. By observation and play with the infant, you can do both a developmental screening examination and an assessment for gross and fine motor achievements. Remember that a clear, well-organized clinical record, employing language that is neutral, professional, and succinct, is one of the most important adjuncts to patient care.
Anterior fontanelle was 1 centimeter and soft. Posterior fontanelle was closed. The right occiput showed mild plagiocephaly. Ears were normal with TMs.
After practice and further review of this video, make sure you have mastered the important learning objectives for examining infants.